Good morning. My name is James Valentine, and welcome to the externally led patient-focused drug development meeting on primary hyperoxaluria. We're coming to you live from the Washington, D.C. metropolitan area, actually not too far from the U.S. Food and Drug Administration headquarters, just outside the city. To open today's meeting, it is my pleasure to introduce my appropriately socially distanced co-host, Kim Hollander. Kim is the Executive Director of the Oxalosis and Hyperoxaluria Foundation. Kim?
Good morning, good afternoon, and good evening. My name is Kim Hollander, and I am the Executive Director of the Oxalosis and Hyperoxaluria Foundation. We are pleased to welcome you today to the externally led patient-focused drug development meeting on primary hyperoxaluria. Wow, I can't believe this day is finally here. It's been a long year of planning, lots of changes have occurred, but being able to spend the next few hours with all of you has made all the planning worth it. A special thanks to the many staff members of the U.S. Food and Drug Administration for taking the time out of your day to join us. We are so grateful to all of you for your interest in this milestone event for primary hyperoxaluria. I know that you're going to learn so much from this incredible, strong, passionate group of people affected by primary hyperoxaluria who are sharing their experiences. We are honored to have you all with us. Another special welcome to our industry partners who have helped make this meeting a reality. Thank you to Dicerna and Alnylam Pharmaceuticals, Chinook Therapeutics, Orphan, a Bridge Bio company, Oxtera, and Intellia Therapeutics. This meeting would not have been possible without all of your generous support. But most importantly, I want to welcome the members of the audience who live with primary hyperoxaluria. This meeting is 100% about you and 100% for you. Almost 2 decades ago, I joined the OHF, and it's been quite the roller coaster ride. We are an incredibly small organization, but since day one, I've always believed that the OHF is a little engine that could and would. Research has been at the core of the OHF's mission, with the hope of getting biotech interested in the severe, profound, rare disease. For years, we knocked on so many doors, but every time we knocked, we were met with disappointment. However, recently our knocks have been heard. Over the past few years, biotech has become very interested in primary hyperoxaluria. Several research studies and clinical trials are already in progress, and many planned for the future. The unmet medical need of treatments and an eventual cure for primary hyperoxaluria is no longer just a vague hope as we move forward. That is why this meeting is so timely and important. Today, many of you will have the chance to share your stories directly with the FDA. You will have a chance to talk about the symptoms of PH, which have had the most impact on your life, as well as comment on current and future treatments. We know many of you from around the globe are affected by primary hyperoxaluria that we're discussing today. We have so much to learn from all of you, and your involvement today is critical. We want to hear from patients and anyone who is a caregiver, including spouses, parents, grandparents, aunts, uncles, siblings, and friends. You'll have the chance to respond to a number of polling questions via your mobile device, tablet, or computer. Also, we encourage you to submit comments through the online comment form and speak to the audience directly by calling us. We ask that each patient and caregiver of any age who participate in live polling to log on individually. We want to include your responses in the Voice of the Patient report, which will summarize this entire public meeting. I know watching this on screen cannot replace all of us meeting in person, but please hang in there. I promise it will be well worth your time. Now, without further ado, it is my pleasure to introduce our first speaker, Dr. Eliza Thompson. Dr. Thompson is the Deputy Director of the Division of Cardiology and Nephrology in the Center for Drug Evaluation and Research at the Food and Drug Administration. Dr. Thompson?
Hi, Kim, and thank you. And good morning to everyone, and I guess good afternoon and good evening as well, perhaps. As Kim mentioned, I work at the FDA in the Division of Cardiology and Nephrology, and I'm here today with many of my colleagues from FDA to listen and learn from you, about your experiences with primary hyperoxaluria. As Kim noted, this is a very exciting time for drug development for primary hyperoxaluria. Because of the important advances in science and because of your efforts and the efforts of the larger community, pharmaceutical companies are developing treatments for primary hyperoxaluria. And so today's meeting is critical. We, the FDA, and our partners in industry, the companies that are developing treatments for primary hyperoxaluria, need to hear from you. We need to learn from you. It goes without saying that patients, the people living with the disease, should be at the center of the drug development process. And yet, somehow, as we developed this whole enterprise, we seem to lose track of that. Fortunately, we as a larger community are working to address this issue. So what do I mean by patient-focused drug development? A key concept is that as experts in what it is like to live with your condition, patients are uniquely positioned to inform the understanding of the therapeutic context for drug development and evaluation. Next slide, please. So what are the overarching goals of this initiative? I show these goals on this slide and the next one, but at a very high level, there are two key components. One key component is listening to patients and learning from patients about what matters to them. The second key component is what I'll call the science part. It's one thing to say that we want to incorporate the patient voice in drug development, but a critical issue is how one actually does this systematically in a robust way. And that's really the science part. Unfortunately, we have a lot of very smart people in the agency and outside the agency who are giving careful thought to this issue. As Kim noted, during today's meeting, we will hear from you about how primary hyperoxaluria has impacted your lives. We will also hear from you your perspectives on current and future approaches to treatment. However, another important aspect of FDA's patient-focused drug development program focuses on the conduct of clinical trials and really encouraging the identification and uses of approaches and best practices to really encourage patient enrollment in clinical trials and minimize the burden of patient participation in these clinical trials. This includes engaging in discussions about the challenges we face in designing these trials. For example, randomized controlled trials are often needed to determine whether a drug is effective and provides a benefit to patients that outweighs its risks. How can we design these trials in such a way that will make you want to participate in them? Next slide, please. Other aspects or overarching goals include understanding, again, some things we're going to learn today about your preferences, but also what we need to understand to inform our decisions is the acceptability of the trade-offs between treatment benefits and risks, because again, no drug is entirely safe. All drugs carry some risks. We also need to have a better understanding of how best to communicate information to you about the benefits and risks of drugs so that you can make a decision about whether a drug is the right treatment for you. Next slide, please. Great, thank you. Over the years, we have been fortunate to participate in a number of patient-focused drug development meetings for kidney diseases. I'm very proud of this slide. You'll see 4 patient-focused drug development meetings in kidney diseases up here, and I look forward to adding your name in this meeting to this slide. Often when we participate in these meetings, we, FDA, are asked to address how these meetings affect the decisions that FDA makes. I suspect that in the years to come, we as an agency and scientists outside the agency will study and attempt to quantify the impact these types of meetings have on drug development. But the best I can do for now is share a response to this question with you on a personal level. Your stories, the stories that we hear at these meetings, are powerful. Although you may see us as regulators, we are people just like you. We have families and friends. We have people we love who have suffered from disease, and some of us have been patients and caregivers. I think we connect with your stories on a very personal level. I think your stories remind us of the urgency with which we must act to address the obstacles to drug development, and they inspire us to do better. I think they speak to why many of us decided to pursue careers in medicine and why we decided to come and work at the FDA. Simply put, it is not enough to be able to diagnose a disease, to be able to tell someone the cause of their suffering. We need to be able to treat it. Next slide, please. So in closing, successful drug development takes a village, and you, the patient, need to be at the center of that village. As I noted before, meetings such as these are a critical means to involve patients in drug development. But these meetings are only one step in this process. To truly accelerate drug development for primary hyperoxaluria, we need you all to remain actively involved, to essentially drive this process, and to inspire and encourage other patients to be involved as well. So from the team at FDA, we thank you for sharing your experiences and stories. We are eager to hear from you and to learn from you. And we look forward to working with you in the future. Back to you, Kim.
Thank you so much, Dr. Thompson, for those very encouraging words. I'd like to introduce our next speaker, Dr. Dawn Milliner, Professor of Pediatrics and Medicine at the Mayo Clinic. Dr. Milliner has been engaged in clinical research in primary hyperoxaluria throughout her career and was instrumental in the establishment of the OHF-founded Hyperoxaluria Center at the Mayo Clinic and the Rare Kidney Stone Consortium PH Patient Registry. Dr. Milliner has been caring for PH more than 30 years and is one of the most prominent leading experts in the world. Dr. Milliner, I will turn it over to you.
Thank you very much, Kim, and good day to all of you. Next slide, please. Hyperoxaluria just says too much oxalate in the urine. And the term primary here means that it comes from within the body, not from the outside. Primary hyperoxaluria is a condition in which the liver makes too much oxalate, in most cases, way too much oxalate. Genetic mutations, that is, changes in the genetic code, result in defective enzymes that don't work in the way that they're supposed to work in liver cells. There are three types of primary hyperoxaluria that are well defined and understood based on which specific enzyme is deficient or defective in each one of these types. Next slide, please. In understanding how many people have primary hyperoxaluria, I think it's instructive to compare it with kidney stones, which, as you know, are quite common. In fact, in the United States, about 1 out of every 12 people will have had a kidney stone at some time or other in their life. By contrast, next slide, please, primary hyperoxaluria is found only in 1 to 3 per million people. It's a very rare disease. To put this in context, let's think about the population of some major US cities. Boston, with a population of 4.3 million. We would expect about 360,000 Bostonians to have a kidney stone at some time in their life. By contrast, just 4 to 13 Bostonians would have primary hyperoxaluria. For Phoenix, 419,000 stone formers, but just 5 to 15 with primary hyperoxaluria. Although the prevalence of hyperoxaluria, primary hyperoxaluria, is somewhat higher in certain parts of the world than in these numbers I've shown you from the US and Europe, it is a rare disease everywhere worldwide. Next slide, please. Before you had or knew someone who had primary hyperoxaluria, you probably had never even heard the term oxalate. Oxalate's a naturally occurring substance found in many plants and animals. There are two sources of oxalate in humans. The oxalate that comes in the food that we eat, our diet, absorbed in the stomach and the small intestine into the bloodstream, but most of it passes right through out into the stool. Oxalate is also made by the liver, and it's a normal byproduct of healthy body metabolism. Byproduct in the sense that it's not needed for anything else in the body. And furthermore, the human body has no way of breaking it down. So all it can do is get rid of the excess. And that's where the kidneys come in. The job of the kidneys is to extract the oxalate made from the blood, concentrate it, and eliminate it in the urine. Next slide, please. Why does oxalate cause problems? Under healthy conditions, the amount of oxalate produced by the liver and in the kidneys and in the urine is low in concentration, and it stays in solution very readily. But when there's too much oxalate made, that oxalate combines with calcium, which is always present in body fluids, and forms calcium oxalate, which doesn't stay in solution very well. It forms crystals. Now, those crystals might pass out in the urine, as you see on the right side of the panel on your screen, showing the kidneys and urinary tract. And that can be harmless, although sometimes can cause some blood in the urine. But the crystals also aggregate, they can get stuck in the kidney, and they can also aggregate together and form larger, larger aggregates of hard masses, which we know as stones. Those stones, which are shown in the left side of the kidney diagram, can stay in the kidney for years, or they may move into the collecting system of the kidney and down the ureter into the bladder and out. As many of you know, this can cause a lot of pain. It can obstruct the flow of urine and cause infection, none of which are good for the kidneys. Next slide, please. The consequences of hyperoxaluria are stones, shown in ultrasound and CT on the top of the slide. Nephrocalcinosis, which is the deposition of those crystals throughout the kidney and makes the kidney look white on this CT scan and visible on ultrasound as well. Those crystals that deposit in the kidney, and they're shown in the microscopic view, which is the purple square that your rectangle that you see there. The white are all the calcium oxalate crystals in the kidney, and the purple is the kidney tissue. That causes a lot of damage to the kidney, and over time, kidneys can lose function. They can progress to complete kidney failure, at which time dialysis or transplantation is needed. When that occurs, the kidneys can't get rid of the oxalate produced by the liver very effectively. So the blood level goes high, crystals form in the bloodstream, and then can deposit in multiple organs: bone, heart, blood vessels, eyes. Serious problem that we try very hard to avoid. Next slide, please. So primary hyperoxaluria is genetically determined, that's inherited, and it's an error of liver oxalate production. There's too much liver or oxalate production by the liver. There are three recognized types of primary hyperoxaluria. Type 1, due to mutations or errors in the genetic code of the gene called AGXT. Type 2, due to errors in the genetic code of the gene called GRHPR. And type 3, mutations of the gene called HOGM1. There are also some people who have high urine oxalate, kidney stones, nephrocalcinosis, and may have kidney damage, in whom we can't find mutations of any of these three genes. We think there are other types of primary hyperoxaluria yet to be defined. Those are called NMD, or no mutation detected. The circle on the right side of the slide shows the frequency of these types. Type 1 accounts for the large majority, 70 to 80% of all the patients with PH that are currently known. Type 2 accounts for about 8 to 10%, type 3, 10 to 12%, and then a smaller sliver due to the no mutations detected group. Next slide, please. The slide here shows the age at PH diagnosis for type 1 in green, type 2 in orange, and type 3 in blue. As you can see, most patients with all three types are first diagnosed in childhood or adolescence, since the hyperoxaluria is present from shortly after birth. But the diagnosis can occur at any age. It can occur in patients in their 30s, 40s, 50s, 60s, even in their 70s, as you see on this slide, if the symptoms are mild or if they're not recognized as being due to primary hyperoxaluria. Next slide, please. Are all PH types the same? Well, there are similarities among them, but there are also important differences. Among the similarities are that all three types are characterized by marked overproduction of oxalate by the liver. The urine oxalate is increased from shortly after birth and present lifelong. As we've seen in this previous slide, all three types have symptoms that most often present in childhood, but can start at any age. Kidney stones are the most frequent first symptom for all, and they tend to recur throughout life. All three types can have kidney damage and loss of kidney function over time. And in all three types, there's wide variability from one patient to another within each PH type, and there's a crossover between the types. So every patient is different. Important differences among the types are that type 1 tends to have higher oxalate levels in the urine, and type 3 lower levels. Now, all three types have very high oxalate. It's just that type 3 are tend to be lower than type 1 or often type 2. Nephrocalcinosis is seen more often in type 1 than other types, and there's a greater loss of kidney function over time in type 1. There's also tends to be better preservation of kidney function in type 3 patients, such that in patients with type 3, dialysis and transplantation are only rarely needed. Next slide, please. PH treatments are directed to protect the kidney from calcium oxalate injury and stone formation. Mainstays of treatment are high fluid intake. When you drink a lot, you make a lot of urine, and that keeps the oxalate in solution so it doesn't form crystals as readily. And medications are taken by mouth, like citrate, that can reduce crystal formation and stone formation even when oxalate is present. Next slide, please. Standard of care for PH in this way protects the kidneys from oxalate damage. High fluid intake and medications to reduce crystals and stones. Pyridoxine, vitamin B6 is used in type 1 primary hyperoxaluria because in some type 1 patients, it can push the defective enzyme to work harder. And we'll talk about that a little bit more later. But it only works for some PH1 types, not PH2, not PH3. Part of the mainstay of treatment is managing kidney stones. And stone formation should be monitored with regular ultrasound or other imaging. And stones that cause pain or obstruction or infection might need to be fragmented with lithotripsy or might need to be removed. It's important to manage kidney function with blood and urine tests at regular intervals to know how well the kidneys are doing. And extra care is required when kidney function is reduced, especially following the blood oxalate level. If kidney failure ensues, dialysis and transplant are initiated when needed. So these treatments assume to some degree that high oxalate is going to be there in patients with PH. They're directed to prevent oxalate injury and to manage it. Next slide, please. But what about the source of the oxalate? If I can have the next slide. Because that's where we'd like to direct our treatment. If we could get rid of the excess oxalate, we can prevent these problems from happening. Next slide, please. So let's talk about treatments directed to where the oxalate comes from intake. We can reduce the oxalate in the diet or take calcium with meals to bind the oxalate so more of it goes out in the stool. In this and the next slide, what's shown in dark blue are currently available and currently used treatments. Those in reddish brown are new treatments under development. And in that category are enzymes and also whole bacteria taken by mouth that can break down oxalate within the intestinal tract. And also bacteria taken by mouth that can increase intestinal secretion, that is to promote blood oxalate to move into the intestine and out in the stool. Next slide, please. Let's move now to therapies that target the liver, because that's where the real problem resides in primary hyperoxaluria. There are other hyperoxaluric states, but in primary hyperoxaluria, the problem is with liver production. Well, we could restore liver function to normal by putting in a new liver. Take out the liver that has the deficient enzyme and put in one that has enzymes that all work normally. And liver transplant has been a wonderful therapy when it's needed. It is effective, it saves lives, but it's complicated. And patients who have a liver transplant have a lifetime of medical monitoring and some risks associated with it. So it's not a perfect therapy, even though we're very grateful to have it. One might also modify liver enzyme activity so less oxalate is produced. And that's where in type 1 pH, pyridoxine comes in. It pushes the deficient enzyme AGT to work harder. And in that way, is able to reduce oxalate production. That's currently available, but it doesn't work for every pH 1 patient. And as I mentioned, does not work for pH 2 or pH 3. Investigational agents under development are now looking at other parts of the enzyme pathway that involves oxalate and targeting different enzymes. And there are new medications that are targeting the GO enzyme and the LDH enzyme, the first in type 1 pH and the LDH enzyme in types 1, 2, and 3 of pH. And by reducing those enzymes, we think that that could reduce oxalate production by the liver. These are under active investigation. Next slide, please. We have promising new agents, but they have to be tested. So what does all this testing involve? There are multiple stages. There's the preclinical stage, exploratory, an idea that a scientist or a clinician has. It has to be tested typically in the laboratory, in test tubes, and then in animals. And if it looks promising, it looks like it can be given safely to humans, it enters phase 1, where the safety and dose is studied in healthy volunteers only. If it appears safe and satisfactory dose can be achieved and an effect realized, then it will proceed to phase 2, studying effectiveness and safety in a small number of patients with the disease, in this case, primary hyperoxaluria. If it looks effective and safe in phase 2, it moves to phase 3 to confirm effectiveness and side effects and safety in a larger number of PH patients. It's only at this point that the FDA makes the decision. They look at all the evidence and they say, this evidence doesn't show convincing effectiveness, or we still have concerns about safety, more testing is needed. Or they may say, yes, this is convincing, it appears to work and it appears safe, and they may approve it. And then it's available to be used widely for primary hyperoxaluria patients. But even after that, the FDA watches. There's a phase 4. The FDA continues watching for years to see if new side effects show up or a different profile is seen than was found in the earlier, more limited trials, to see if the effectiveness bears out. So they're always watching out for our safety. Next slide, please. Now, these investigational agents are well along. Several of them for primary hyperoxaluria are phase 3 testing and will be able to be reviewed by the FDA before too much longer. Others are at phase 2 or even preclinical stages. Now, this slide has a lot of detail. It's on the OHF website. So if you want to look at the details more clearly, you can go there and spend some time to study the content. Next slide, please. We've made solid progress in recent decades in defining the genetics, the errors in the oxalate pathway, the causes of kidney damage in pH. We have a much better understanding of disease expression over the lifetimes of pH patients now than we did in the past. and outcomes are improving. PH patients are healthier longer than they ever were before. But the glass is also half empty because fluid intake and medications are a daily burden. Kidney stones are painful, unpredictable, they may need surgery, and they interrupt your life at the most inconvenient times. Loss of kidney function and kidney failure can occur despite your best efforts and our best efforts as your clinicians. And if kidney failure develops and dialysis is needed, it's intense and it's very burdensome. Transplantation has long-term consequences, so it too is not a perfect solution. Next slide, please. We must do better, and we will with your help. Next slide, please. I'd like to thank so many PH patients and their doctors, the Mayo Clinic Hyperoxaluria staff, the OHF, and the NIH and Rare Disease Clinical Research Network for their support of the Rare Kidney Stone Consortium. It's important also that I let you know that I do consulting work with a number of the pharmaceutical companies who are developing new drugs at this time. I have never been more optimistic about the long-term outcome for PH patients than I am at present. But I have to leave you with a challenge because the work ahead of us, if I can have the next slide, please, cannot be done without you. The challenge to you is to participate in PH registry so we continue to learn more and more and more about this disease and whether the new treatments becoming available are better than the old treatments that we had and in what ways. You are needed to participate in clinical trials. These agents cannot be tested unless patients volunteer. Help scientists, clinicians, the OHF, and the FDA understand what you need in the way of new treatments. Educate your families, your friends, and your care providers who probably have had no reason to know much of anything about primary hyperoxaluria in the past. And above all, support each other. Thank you for the opportunity to be here today, and I'll turn it back to Kim in the studio. Thank you.
Thank you so much, Dr. Milliner, for that incredible overview. We really appreciate all your time. I am so excited to introduce to you to my co-host, James Valentine. James is our moderator for today. James and his colleagues have been working with the OHF for the last year to help plan for this meeting. James previously worked at the FDA, where he helped incorporate the patient voice into decisions about medical devices, as well as helped establish the PFDD meeting. James has worked with many groups like ours, and with a shift to externally led patient-focused drug development meetings, has helped run nearly 75% of these events. We know we are in very good hands with James. James, it is my pleasure to turn the meeting over to you.
Oh. Well, thank you so much, Kim, and it's really my pleasure to be here and have the opportunity to serve as your moderator today. So now that we've heard from a clinical overview from a disease expert, as well as from a colleague from the Food and Drug Administration, we now turn to the core of today's meeting, which is to hear from you, individuals living with primary hyperoxaluria, and their direct caregivers about the experiences of persons living with PH. Patient-focused drug development is a more systematic way of gathering patients' perspectives on their condition and on available treatments. As you heard from FDA's Dr. Eliza Thompson, your input can help inform the agency's understanding of PH to inform drug development and review. Dr. Milliner walked us through all of those stages. So far, FDA has held 27 of its own patient-focused drug development meetings, and today marks the 39th externally led PFDD, and due to the ongoing COVID-19 pandemic, the 7th fully virtual PFDD of its kind. With over 7,000 known rare diseases alone, this is a unique and important opportunity for this community. So let me tell you a little bit about what today's meeting is going to look like. Today's meeting is interactive, and so we're going to be asking you to participate throughout the day. First, we're going to be exploring the patient and caregiver experience with living with PH and its impacts on daily life. We'll then build on that in our second session. We're going to bring everybody back together to explore the various approaches to treatment. We will also be asking your preferences for future treatment for primary hyperoxaluria. So what will those two discussions look like? Well, we have really three main ways or methods, so to speak, that we'll be using to engage with you. We're going to start by first hearing from a panel of patients and caregivers living with PH. Those people were selected to reflect a range of experiences with the condition, but of course can't speak for all of the experiences, which is why it's so important for us to build on that through your hearing your voices throughout the day. And we do intend for them to, however, set a good foundation for that discussion. And we will build on it then by opening it up to all of you who are tuned in live with us. We'll have a facilitated audience discussion where all of our patients and all of our caregivers who are tuned in today will be invited, be asked questions and invited to provide comments. We'll ask you to do this in one of two ways. We will ask you and give you a dial-in number where you can call in by phone and actually share live with us over this broadcast your experiences, your stories. You can also write in with written comments using the comment feature that's on the OHF webpage where the live stream is located. We'll also have a Zoom panel of patients and caregivers who will be sharing their experiences during those times. When you do, whether you're writing in or you're calling in, whenever you are sharing a comment, we will ask you that you share your first name and the type of pH that you have before that you answer. The third and final way that we're going to be getting your input throughout the day is through the use of polling questions. We're going to ask that our patients and our caregivers use your phones or other devices to, on the web, on your browser, answer some questions for us. This will really broaden the discussion so that everybody can answer these questions and help aid in the discussion. I also want to mention that we have a couple of opportunities to provide written comments even following the meeting. So whether you're with us today and you aren't able to share everything that you wanted to share, or perhaps you're tuned into the replay of this video and you're watching it on demand right now, your comments, you can submit those for 30 days after the meeting using that same comment box that will remain live and open under this broadcast. All of today's input and the written input will be summarized in a Voice of the Patient report, which will be provided to the FDA as well as made publicly available for research and developers. So one final thing before we move into our first set of polling questions with you all is I want to set out some ground rules for today. We encourage individuals with PH and their direct caregivers to contribute to the dialogue. Again, that's by polling, calling in by phone, and submitting written comments. This is limited to individuals with PH and their friends and family members only. Our colleagues at the FDA, drug developers, and clinicians are here to listen. Also, views expressed today are inherently personal, and the discussion may get emotional at times. So respect for one another is paramount, and to that end, we do ask that you try to be focused and concise in your comments so that way we can hear from as many voices as possible. So without further ado, let's get into it. Let's go ahead and we're going to go to our first set of polling questions, some demographic polling questions that we have to get a sense of who we have in the audience today. So if you can pull out your phone, open up a web browser, open up a tab in your web browser on your computer. If you're following along on a computer today, you can type in the URL that you see listed on the slide here. It's www.pollev.com/OHF-PFDD. You can go there. Just keep that up throughout the day. We'll be coming back to it. The questions will automatically advance. So you don't need to do anything once you keep it open. Every time we come back to some questions, you'll be able to participate there. So here we want to know of our audience members, our patients and our caregivers, we want to know, are you A, an individual living with PH, or B, a parent or other caregiver of an individual with PH? And remember here, caregivers, we want to know all of you that play some role in a person with PH's life. So, whether that's immediate family, extended family, even friends. If you're tuned in today and have that personal relationship with someone with PH, we want to hear from you. So you can select B. So we know this is our first question. We're going to give you some time here to get logged into the system, answer this first polling question. That way we can know who you are as we advance through all of our questions here today. So we'll give you just a couple more moments here. It looks like the responses are trickling in here at the end. So from where it stands, it looks like we've got about almost 3/4 of our participants today are parents and other caregivers. And then about 1/4 of our participants today, a little bit over 1/4 of our participants, are actual individuals living with PH themselves. So thank you for answering this first question. We'll go to our second polling question now. So here we want to know where you live, and if you're responding as a caregiver, these questions are going to be about the patient that you care for. So where does the individual living with PH live? And your options here are A, in the U.S. Northeast, B, in the U.S. Mid-Atlantic, C, in the U.S. Midwest, D, in the U.S. South, E, in the U.S. Mountain region, F, in the U.S. West, G, Canada, H, Central or South America, I, Europe or the U.K., J, in Asia, K, Africa, L, Australia or New Zealand, or M, some other area or region not shown on this slide. So this is where you, or if you're a caregiver, your loved one lives. So it's looking like, as it stands, we've got some good representation both across the U.S. and around the globe. We have a little over 1/4 of our participants from the U.S. Northeast, but we do have really good representation across all of the different regions across the United States. Thank you for all of you tuning in from the mountain region and the West Coast with us a little earlier in your time zone here today. Also looks like we've got some good representation from outside of the U.S. with Canada, Europe and the U.K., even Asia and Australia and New Zealand, as well as some others. So really appreciate the wide range of participation here today. Looking forward to hearing from so many of you. If we go to our third polling question. So here we would like to know the affected individual's age. So if you're a patient, that's your age. If you're a caregiver, the person you care for's age. The options are A, younger than 12, B, 12 to 17 years, C, 18 to 29 years, D, 30 to 39 years, E, 40 to 49 years, F, 50 to 59 years, or G, 60 years of age or older. I promise these questions will be a little bit more maybe interesting or challenging to answer a little later in the program. We do really just want to get a sense of who exactly we do have participating today. So valuable to know. So we'll give you a few more moments here to answer this question. What is the age of your age or the person that you care for's age if you're a caregiver? As it stands, it's looking about like 1/3 of the patients we have represented today are younger than age 12. About 1/5 are between ages 12 and 17. Just about 15% in the 18 to 29 age range, and a little over 10% in the 30 to 39. However, we do have participation across all age ranges, including some of those older age ranges. So we can go to our fourth polling question, please. So here, do you or the person with PH identify as A, male, B, female, C, non-binary or gender non-conforming, or D, if you prefer not to say? Give you a few more moments here to answer this question. See responses coming in. Still, it's looking like we're seeing about 60% of our patients are male and a little under 40% are female. Little fluctuations up and down, but pretty much sticking to about that ratio. We go to our fifth polling question. So here we want to know about which type of PH that you or your loved one have been diagnosed with. Is it A, type 1, B, type 2, C, type 3, or D, if it's not known or you don't know? So while this is coming in, it looks like over half of our individuals today are representing PH type 1, pretty consistent with what we heard from Dr. Milliner in terms of the kind of demographics of what's known about the overall PH patient community. But we do have good representation from types 2 and 3, between 15 to 20% of our audience today representing those types, and then a small proportion, under 5%, that don't know. If we go to our sixth polling question. So here, we just asked you what your diagnosis was. Here we want to know what is the age that you or the affected individual was diagnosed with PH. So where did you get that formal diagnosis? The options are A, between birth and 2 years of age, B, between 3 and 8 years of age, C, between 19 and 18 years of age, D, in adulthood, which is age 19 or older, or E, if you're not sure when you or your loved one was diagnosed with PH. So just give you a few more moments to answer here. As it stands, it looks like about half of our audience was diagnosed between birth and 2 years, about a third of our audience, just under, between 3 and 8 years, and then about 5% in those adolescent, 9 to 18 years, and then we see about 10% that were diagnosed in adulthood. Not terribly different from also what we heard from Dr. Milliner in terms of the when patients are first diagnosed, from what's known in the general PH population. So very representative population here today. If we go to our seventh and final demographic polling question, so now that you told us what age you were first diagnosed, we'd want to know what age did you first have kidney stones, or did your loved one first have kidney stones? The options are here: A, between birth and 3 years, B, before 4 and 10 years, C, between 11 and 18 years, D, between 19 and 40 years, E, 41 to 60 years, F, 61 or later, or G, if you've never had a kidney stone. So again, what age did you or your loved one first have kidney stones? All right. This is somewhat pretty overlapping with age of diagnosis here, but we're seeing about half between birth and 3 years, and about a fifth between 4 and 10 years, about 10% between 11 and 18. But some people did not have their first kidney stone until they were between 19 and 40, or even later into adulthood, 41 to 60 years. No one reports having their first kidney stone at age 61 or after, and we do have about 10% of people who have never had a kidney stone. So I want to thank you all for participating in this first set of polling questions. Again, very valuable for us to get a sense of everyone we have participating today. We're now going to go into that first topic that I mentioned, which is really learning from you all about what it is to live with PH. What are the symptoms, the health effects that impact you in your life, and what does that look like? What we're going to see here is a list of the discussion questions that we're going to be addressing during this panel. We're going to be asking you to think about what are the maybe 1 to 3 symptoms that have had the most significant impact on you or your loved one's life. How have those symptoms changed over time, whether that's variability from day to day, week to week, month to month, or even over the course of years of progression of the condition. Maybe one way that it might help us understand it is, what does one of your best days look like compared to one of your worst days? We also don't want to just know what the symptoms are and health effects are, but we really want to understand what that looks like and how that impacts your life. And so we're going to ask you about what specific activities that are important to you that you or your loved one are not able to do either at all or as fully because of your PH. And then finally, we're going to end our session today thinking about knowing that not all of the symptoms or the impacts in your life might be ones that you've already experienced. They might be things that could happen in the future. So we want to know about what your fears, what your worries are about you or your loved one as they get older living with PH. And are there any capabilities that you're concerned about potentially losing as you grow older? So to get us started on these questions, we have a great panel of some members of your own community to share their experiences living with PH. We have Natalie, Amy, Jamie, Kyle, and Jessica who are going to share their stories. So Natalie, take it away.
My name is Amy Blake. I am from Pennsylvania. My 12-year-old son, Owen, was diagnosed at 5 years old with primary hyperoxaluria type 1. Owen's journey with primary hyperoxaluria began at birth, even though we didn't know it. We spent the first 3 years in and out of inpatient hospitals and long-term skilled stays. We had no formal diagnosis and limited genetic testing resources available. At 4 months old, Owen received his first of many surgeries to place a feeding G-tube as he suffered from failure to thrive and was only in the 3rd percentile for growth and development. At 14 months old, Owen received his first pacemaker. We've had 2 more since then. As a result of low heart rate, lethargy, and blue episodes from calcium deposits in his AV node, he suffers from renal tubular acidosis, which aided in his inability to gain weight. He has broken many bones due to the brittle nature of them. Then, finally, he would have his first momentous kidney stone at the age of 3. It would take 2 more years and a dozen more stones until we were able to receive his formal diagnosis by a random provider that we encountered at the age of 5. At the age of 6, Owen began to wake up in the middle of the night with severe headaches. After an emergency room visit, we came to find out that Owen had not 1, but 2 brain malformations because of primary hyperoxaluria. His soft spots fused together too soon from the overproduction of oxalate. As a result, Owen had to have a cranial vault to alleviate the increased pressure on his brain. He would have surgery in October. In November, while healing, he began to complain of severe stomach pains. The first time it was just a headache. This time a stomach ache that resulted in a 3 by 1 centimeter kidney stone. Try to pass that. This had to be removed through his belly button. During his heal time from surgery, Owen received his first stent. This stent was something that nightmares were made of. New Year's Eve, Owen writhed in pain and in total hysteria. When we went to remove his stent, we learned that in very short time, the stent that was in place had encrusted itself to Owen's kidney and had to be laser removed. It was this stent removal that the urologist suggested we start to round with our local transplant team. Owen's oxalate production was through the roof. Owen's journey and progression slowly continues into deterioration. Each year we lose more kidney function and hype ourselves up to prepare for the inevitable dialysis and organ hunt with each blood test. He has had to forego sports, which he would love to participate in. He has missed many sleepovers and birthday parties. Who wants to send their kid to a sleepover when the parents are unsure of how to handle him if he begins to pass a stone or has another medical issue related to his disorder? What parent wants the responsibility of a kid who has these issues when it's not yours? What kid feels comfortable enough to tell somebody else's parents, I'm peeing blood, I'm in pain, and I need my mom to come and pick me up? If I can't be present, then he can't attend. In 1st grade, Owen was not allowed to go on a field trip without me because his medical condition was so complex, they were admittedly scared of him. That school year, Owen missed 108 days of school due to his disease, which is a pattern for Owen every year. He misses a significant amount of school. Do you have any idea the impact that has on the coming years for cumulative education? He has gaps by no fault of his own. If I had to pick 3 things that impact Owen's life the most because of PH, it is that Owen never feels well. He has a constant level of pain that is never ending. He suffers horribly from dizzy spells due to his impaired renal function. He is quick to fatigue and lacks the stamina to play and be a normal 12-year-old boy. It is horrible that our normal for Owen is never really being healthy in the way that we all take being healthy for granted. I will champion for Owen in this so very important cause until the end of my days. If it does not make a difference for him, it will make a difference for another 23-year-old mother with a newborn baby who is planning his funeral by the time he is 5 years old because his only treatment option is a transplant that may or may not come. We are better than this. We can do better than this.
My name is Kyle Rosen, and I'm a patient with primary hyperoxaluria type 3. Shortly after I was born, I had a fever and a urinary tract infection and was later diagnosed with kidney stones. Nobody knew why I had these symptoms, and I was in and out of hospitals for the first couple months of my life. My parents were left wondering why their youngest of 3, who appeared completely normal on the surface, was suffering from so much pain. Their child was diagnosed with an unknown version of a rare disease, needed multiple surgeries to remove his kidney stones, and was immediately put on a strict diet and began a rigorous but experimental medication plan. For as long as I can remember, pH has defined my life. As a young child, I often questioned why I was the 1 in a million to be diagnosed with this rare condition. I found myself comparing my condition to my peers and not seeing many differences on the surface. Unlike many other diseases, pH does not manifest itself in physical appearance. Rather, you can look completely normal, participate in the same activities as everyone else, go to school, and appear completely fine. On paper, it was easy for me to convince myself I was, quote, normal. It wasn't until I realized that none of my friends had to eat a specific lunch made for them each day or make daily trips to the school nurse for their lunchtime medication that I realized I was in fact different. In addition to taking multiple days off of school for my biannual trip to the Mayo Clinic in Minnesota for a routine checkup, everything began to seem less and less normal. As a child, it was merely impossible to comprehend how the food I ate converted into kidney stones, and having an unknown version of an invisible disease didn't make it any easier. The emotional toll of trying to explain pH to my peers only made the suffering worse. As I got older, trying to hide my condition from my friends became increasingly more difficult. I was unable to attend sleepovers from a young age because I continued to wet the bed until the age of 10. During one summer at camp, I began noticing blood in my urine and experiencing this common back pain that many patients describe at the onset of a kidney stone. Rather than going home and leaving camp early to address the issue, I chose to stay at camp and passed a kidney stone over a couple of weeks. I did all of this just so that I could pretend I was like all the other campers. Experiences like this have been present throughout my life. Fast forward a couple of years, at the age of 14, the doctors who had been studying pH discovered the specific enzyme my body was missing. This was an amazing breakthrough at the time. However, my experience with the disease did not change. For many years, my condition was seemingly under control. My body was accustomed to eating a low-sodium diet and drinking multiple liters of water each day. During college, many of the same issues I suffered from as a child began to manifest again. The kidney stones returned, my medications changed over and over, and the surgeries have been constant. As I moved out of my parents' home and into the adult world, it became increasingly more difficult to follow the strict diet and medical regimen I was accustomed to. While I was able to go to college and get a job after school like many of my peers, my first years of adulthood have been quite challenging. I'm currently living on my own and working in an industry that does not look lightly on taking days off from work. Within the first 6 months on the job, I began experiencing a similar pain I had throughout my life. I knew I had a kidney stone, but I had no idea the extent of it. During the sonogram, I was told I would need a bilateral ureteroscopy to remove 8 kidney stones. At the time, this was the 3rd surgery I would have in just over 1.5 years. I was forced to take a week off from work and to recover from the surgery and explain to my bosses why I could not fulfill the duties of my job. I'm currently 24 years old, and primary hyperoxaluria is still a defining feature of my life. While I look and seem like every one of my friends and colleagues on the surface, on the inside I am impacted by this disease daily. I still take medication 3 times a day, drink an abundance of water, and keep a fairly restricted diet. I still visit the Mayo Clinic annually for checkups, and I'm constantly trying new medication regimens to control the production of stones. In addition, I also do 24-hour urine collections and blood work every few months. While my body has continued to change throughout my life, pH has been a constant. The doctors and scientists continue to research this unknown condition, but the status of the disease has remained the same. It still impacts patients like myself and remains largely ignored by the medical community because of the small patient small patient sample size it impacts.
Hello, my name is Jamie Schmidt and I live in Byron Center, Michigan. I'm the mother of 4 handsome boys and the caregiver to 2 boys with primary hyperoxaluria type 2. Today I will be sharing a little bit of insight into our life with PH2. Our journey with PH2 began 12 years ago in 2009. My youngest son Gunnar, then 17 months old, became extremely ill. Gunnar was a healthy child leading up to that day. He was also a very active toddler and also didn't have any illnesses out of the ordinary. Gunnar's pH presented on a February morning with vomiting, high fever, and with him acting very cranky. He was also very cuddly that day. Gunnar was unable to keep any food or liquids down. Shortly after we arrived at the emergency room, we were admitted, and this was in Fredericksburg, Virginia, because we were a military family. The initial symptoms he presented and remained with even after his treatments at the hospital were vomiting and the dehydration concerns. The most vivid memory of that hospital stay was when the medical team came into our room at 3 a.m. to give Gunnar a scan with concerns that his fever and vomiting were uncontrollable. The results of that abdominal scan did rock our world. Gunnar's kidneys were completely filled with kidney stones. Both of his little kidneys were completely blocked off. This meant he was going to need surgery. We heard repeatedly that kids are not supposed to have kidney stones. My husband and I had no idea what would be transpiring after those findings. We did not have any family history of stones, and this totally added to our confusion. Gunnar's initial symptoms and continued symptoms surrounding stone events or infections tend to be very similar. Of course, we see pain, vomiting, fever, all occurring repeatedly. As a toddler who wasn't able to vocalize his feelings or needs, it was important as a parent to monitor and identify his symptoms. I feel like I was much more in tune to his needs after his first initial stone discovery. From this time on, his stones were discovered, our life was completely altered. Additionally, we began our relationship with the Rochester Mayo Clinic. Shortly after his first surgery, we began considering that his stones may have some type of genetic connection. Since this moment, Gunnar has endured 24 total surgeries through 2 separate hospitals, and Gunnar's body is covered in scars. He does look like he's a survivor of a shark attack and is often asked that by his friends. Gunnar's liver biopsy came back positive for a mutation that we had never seen before, and showing the absence of GRHPR, which was consistent with PH2. Our family had genetic blood testing, and it was determined that our oldest 2 sons were genetic carriers, while our 3rd son, Alex, was an exact mutation match to Gunnar. This diagnosed Alex with PH2 in August of 2009. Although Alex and Gunnar have the exact mutation, Gunnar was on the extreme spectrum when it came to stone formation and surgeries, where Alex has been completely mild and has not required any surgery. As they grow, this is reversing. Gunnar's stone formation is slowing, but he has had the most damaging effects seen to his kidneys, and due to his surgery and oxalate levels. My boys are required to drink 3 liters of water a day. If they exercise, play sports, or do anything out of the ordinary, that water requirement increases. They also are required to maintain a lower sodium diet, or at least requested to do so. Gunnar has had multiple hospital stays outside of stone intervention. These include pain management and infection treatments. For those additional hospital stays, the symptoms were dehydration, pain, headaches, and then of course the pain that comes with a UTI, which also presented with lack of urination and belly pain. We spent 2 to 3 months for almost 2 straight years in the hospital with Gunnar for surgeries or brief stays. We also had multiple instances where they were at friends' houses or in the middle of a sporting event when the pain strikes. It is hard to try and maintain a normal lifestyle with uncertainty of a stone event. Our fears include any pains, back pain, belly pain, or groin, and or fevers that warrant a call or trip to our ER, which I do have those numbers on speed dial. I want to share, that our life with PH is filled with constant pain and worry, and the fear that future will bring something far bigger than that, or just another stone or 2 or 3, is something that we have to live with. Once the damage is done, it is done, and it is irreversible. The struggles my boys and family have faced due to this disease has impacted our lives and continues to do so on a daily basis. Thank you.
Hi, my name is Natalie, and I have PH. I will be 31 in a few weeks, and as a healthcare professional myself, I know it can be easy to see patients as just that, patients. So before I embark on the impossible task of describing what it's like to live with PH, I first want to establish myself as a person. I am a pediatric physical therapist, I am a fiance to my partner of 9.5 years, and last but not least, I am the daughter, a sister, and a friend to so many wonderful people. PH1 has threatened to take all of these roles away from me. PH is more than a kidney stone disease. It impacts not only my body, but also my mind, because each day it threatens to take away my future. I was diagnosed at age 5 after passing a kidney stone. When I was a child, we bought every type of water bottle to convince me to drink water, the main treatment for PH. We experienced me coming home in tears because I was the only person in school with a water bottle on her desk. My mom sent separate treats to birthday parties because a low oxalate diet was required, and FYI, chocolate is not low oxalate. By the time I was a teenager, I was tired of being different. In February of 2018, the wrath of PH showed itself. After years of being compliant with my treatments, my yearly ultrasound showed stones that had been accumulating over the years and had more than multiplied. I was referred to a urologist for kidney stone removal surgery. While waiting for surgery, I started to feel poorly, chills and fevers. I thought I had the flu. So I went home and rested. Mistake number 1. Later that evening, I awoke in the middle of the night with the urgency to use the restroom and extreme pain when I did. The pain was so bad I walked myself to Walgreens at 2 a.m. to get medication because Google had told me it was most likely a simple UTI. Mistake number 2. The following day, I called my primary care and received a prescription for a UTI. Mistake number 3. These may not seem like huge mistakes to you. They may not even seem like mistakes, but they are when you have PH. 3 days later, with no reprieve from my symptoms, I found myself lying on the floor of my apartment on the phone with my parents who told me, "Natalie, you have to go to the hospital now." At this point, I had severe abdominal pain, so that each time I drove over a bump in the road, I screamed out loud. I was admitted, given intense pain medication, and told my antibiotics were wrongly prescribed. I now had a very serious kidney infection. I was treated with IV antibiotics and sent home, only to return days later with the same terrible symptoms: nausea, fever, chills, abdominal pain. This pattern continued for several weeks until I was septic. I ultimately received a medication that worked, but the infection was so bad it would take weeks of antibiotics. A PICC line was inserted and home health care was set up. After recovering, I finally had my surgery. We later found out the surgery damaged my kidneys and they would never gain that function back. I also required 2 more hospital admissions as I had to pass stones after the surgery. The pain nearly made me pass out. Medically, I experienced a lot of pain, but the emotional impact is what I remember daily. I've always known I have PH, but I saw firsthand how fast it could change my life. It's a sinking feeling to know that your whole life could be different from that moment forward. That is something I will always remember. So now, I have to continue to consider PH in all that I do. As I take my 6 pills in the morning and my 6 pills at night, when I'm ready to go to bed, but I have to get up to drink 8 more ounces of water before I finally go to sleep, when I get a fever and think about going to the ER, when I seek medical help and have to be concerned if the medical professionals actually know how to help me, when I choose where I live, being sure to be close to a nephrologist I trust, and when I plan my career, making sure to always have insurance and choose an employer that allows me to attend all of my medical visits every few weeks. In all of these daily things, I have to consider and think about PH. I have anxiety about my daily routines, but also about my future. I hope to expand my life roles to include those of wife and maybe even mother someday. However, I could become very sick before my wedding, or worst of all, I could discover that my future children have PH too. My heart sinks each time I consider that real possibility. Today I am healthy enough to make this statement to you, but tomorrow I might not be. I hope you begin to understand that people with PH are fighting a daily, emotional, financial, and physical battle for their lives and their futures. Thank you for your time.
Hello, my name is Jessica. I am mom to 4-year-old daughter Willa, who has primary hyperoxaluria type 2. Willa is a very friendly preschooler whose smile and laugh will make you smile and laugh. As Willa gets older, she's becoming more aware of her disease and what she needs to do right now to keep her healthy. In her early months of life, Willa was a thriving baby. She was a very happy and a very wiggly little girl. That all changed when we rushed Willa to the hospital at 4 months old due to her uncontrollably vomiting and having diarrhea at the same time. She also went limp. The doctors at our local hospital diagnosed her with a UTI. We didn't think anything of it, as we have dealt with our children having UTIs in the past, but this started to get worrisome when she had her second and third and fourth UTI in a span of 2 months. We then were referred to another local hospital who had more knowledge in the urology field than our local doctors. They looked inside of her bladder and they did an ultrasound on her kidneys. When the doctor read the results, he told us she had an 8mm kidney stone in her right kidney and several small stones in the right kidney as well. At 9 months, she was officially diagnosed with PH2. To say we, as her parents, were shocked is an understatement. This makes me remember how hard life was with Willa with her first 2 years of life. I remember missing a trip to the beach with my family when Willa started showing symptoms of what I thought was a stomach bug. She cried and moaned all day. This was one of my worst memories, as I now know what kind of pain she was in. I remember times where she would breastfeed multiple times during a 24-hour period and know it was because of her being in pain. This rare disease has changed my family's life. It has changed Willa's life. Since her diagnosis, Willa has gone through 3 surgeries. Just before her first birthday, she got very sick. We thought it was influenza since we all had it as well, but one day she completely stopped nursing. She didn't have a single wet diaper. She vomited all she had left in her. I became very nervous that something else was wrong. I took her to the pediatric emergency room and explained she had PH2 and her symptoms, and they decided to do an ultrasound of her kidneys. The nurses and I were shocked to see the result of why she was so sick. Willa had the 8mm stone stuck in her ureter, and she had to have emergency surgery. The next morning, Willa and I went to the surgery floor, and I gave my baby to the hands of the nurses, and I waited alone for hours until the doctor came to tell me the stone was removed. She had to have a nephrostomy tube in for about a month to help her kidney drain excess fluids. She had a stent put in her ureter to help repair the damage the stone had caused. The other surgery she had a month later was for the removal of smaller stones and then a placement of a G-tube to help Willa with hydration. She gets over 2 liters of water through her G-tube daily, and we are working on getting her to drink more water orally. Since her surgeries, Willa has been stone-free and is in stable condition, but that doesn't mean she hasn't had her share of hardships. There are still times when she is throwing up and I wonder, could this be another stone? Now that Willa is able to communicate her pain verbally, she will tell us what hurts and where. A few weekends ago, she told me her lower back hurt. This past week, she had a stomach ache and a fever. This happens every few months where bouts of vomiting and fever happen, and I always am fearful that this could be the day another stone forms. As her mother, I am tired. Willa receives some of her water through her tube at night when she sleeps, which means for me, I get up every few hours to change her diaper. There have been many accidents and many tears shed of frustration that I didn't do my job for her and wake up to prevent those accidents. At times, I feel defeated, that I am not enough for her. I am thankful Willa and I got through the toughest of times of her life so far. She's a very strong girl to endure that much pain and suffering. Like I previously said, Willa is currently stable, but once she gets older and goes to school and is required to drink water orally during the day, will she be susceptible to producing more stones? Will she eventually need a liver and kidney transplant? This disease does not have a one-size-fits-all plan. I hope for a medication for Willa so she will never have a kidney stone again, so she's able to eat whatever she wants and live a life without worrying that she didn't drink enough that day. In a time where medicine and more rare diseases are coming forth and more ways to control their outcomes, Willa has been put on this earth at the right time. I hope she, as well as her community of those with primary hyperoxaluria, can be of help to science and medicine, so those that are born or are going on with life undiagnosed will have a better chance at living a life without forming kidney stones.
Wow, thank you, Jessica and Willa, and really all of our panelists for being so brave to share your stories with us, your stories of what it is to live with PH and what that looks like in your daily life. Now, this is our first opportunity to build and broaden that discussion with all of you who are joining us live today in the audience. If you want to share your stories of living with PH, this is a time that we would like to invite you to call in and join us to share your stories live over the phone. That phone number, this is the first time we're sharing it today, is 1-703-844-3231. Again, that number is 1-703-844-3231. We'd love for you to call in. We'll get you in the queue and take your comments here live today. You can also, of course, share your written comments throughout the entire program using that little comment feature that you see under the live stream on the webpage here today. I also like to welcome and join our Zoom panelists who have joined us for this conversation. But before we go to any comments, we want to first start with a couple of polling questions that we have to try to really understand what the impacts and the greatest impacts that PH has been in all of your lives. So again, if you're just joining us, you maybe weren't able to join that first set of polling questions. This is a time to pull out your phone, open up a browser. You can open up a new tab on your computer if you're following along online that way. And just go to pollev.com/OHF-PFDD. That URL is up on the screen right now. You'll be able to stay on that web page throughout the entire program today, and the questions will advance for you. So our question here, our first question of this session, to get a sense of the different symptoms and health effects of PH that you all experience, we'd like to know which of the following of these PH-related health effects do you or your child or loved one have had or recently had? And here, select all those that apply. So the options are A, kidney stones, B, decreased kidney function or end-stage renal disease, C, failure to thrive in infancy, D, swelling in hands or feet, E, blood in the urine or hematuria, F, urinary tract infections or pain when urinating, G, fatigue, H, bone fractures, I, pain in the body, J, nausea or vomiting, K, chills or fever, also infections other than urinary, L, heart or eye problems, M, anxiety or depression, or N, some other health effect related to your primary hyperoxaluria that you or your loved one, if you're a caregiver, have, that they've had or recently had. I want to point out here that this is the first question we're seeing where our respondents can answer with more than one response. So what we're seeing is a percentage of responses, not a percentage of people who have given any particular response. So you can think of this as bars. The longer the bar, the kind of the higher the ranking. So right now, as we see that the number one most experienced health effect by those responding today is kidney stones, followed after that by kind of a cluster of other symptoms and health effects, including decreased kidney function and end-stage renal disease, pain throughout the body, urinary tract infections or pain when urinating, blood in the urine or hematuria, and nausea or vomiting. So we're seeing quite a few symptoms being with a large proportion of our participants today reporting those. However, we do see experience with all of the different pH-related health effects, everything from fatigue to swelling to bone fractures and heart and eye problems, some of those more systemic oxalosis kind of impacts that we heard about from Dr. Milliner. And we also hear about we see a number of people reporting other symptoms and health effects. So we definitely want to hear about those other things, maybe less common, or maybe you just experience it a little bit differently. Please call in, write in with those comments. We'll go to our second polling question. So here we have those same, you'll recognize the same set of response options, but unlike before, here we want you to pick those up to 3 that are the most troublesome pH-related health effects that you or your loved one have. So think about all of those different symptoms and health effects that you just selected, which, up to 3 of those have the greatest impact on them and their lives, or if you're an individual living with PH, on your life. This takes a little bit more thought here. I promised you earlier that these would get a little bit more challenging, and so this is one of those where we want you to, of those, knowing that all of them are probably troublesome, which are the top 3 most troublesome? And it's the same options as before. And as you're responding to this, I want you to think about why it is you're selecting these different options. And that's what we want to hear from you about during this session. So we'd love for you to call in and write in and share with us why it is you're selecting these different symptoms as being your top 3 most troublesome or most burdensome. What was the reason you picked one over maybe another symptom that you have or your loved one has? So as it stands, it looks like the symptom that was most experienced also is reported by the most individuals as being a top 3. Again, this is percentages of responses, followed by, and behind that, in kind of the second top symptom being the decreased kidney function or end-stage renal disease. After that, it drops off quite a bit, and there's more kind of divergence, a number of things being reported by many people as top 3, but kind of separating from those other 2, we see anxiety and depression, pain in the body, and urinary tract infections and pain while urinating. But other than swelling in hands or the feet, each of these different health effects is rated by some number of you as your top 3, meaning it's having a really significant impact on your lives. And so we want to hear about how all these different symptoms are impacting you, not just the most common ones. And again, we're seeing some more others. So something that's not listed on this slide is actually one of your top 3. So we really want to hear about those too. So with that, let's broaden the discussion and let's bring our Zoom panel into this. So we have some members of your community, some individuals living with PH, and some caregivers who are going to be sharing their experiences with us, in addition to those of you calling in and writing in. So thinking about that polling question that we just had, and what were the top 1 to 3 symptoms that have had an impact on you or your loved one's life? I was wondering, Lily, maybe what were you thinking? What did you pick, and why? Lily, you're on mute. Oh, there we go.
Right. I selected, like you mentioned, kidney stones being the most predominant, having had them my entire life constantly, maybe with a couple-month gap somewhere around the age of 30. I forgot to introduce myself. My name is Lily. I'm about 40 years old with primary hyperoxaluria type 1. And I was diagnosed when I was 8. The second would be pain while urinating. It's actually both pain and difficulty urinating, and that's been something that's changed over the years. And then third I selected was anxiety and depression, just because of the unpredictability of the disease and kind of the inevitability of disease progression.
Sure. Would you say those would maybe 10 years ago been the same top 3 that you would have picked as you've picked today?
I think so. It's hard to know where to place the impact of the surgeries, since those are more acute episodes, as opposed to maybe thinking about what's the ongoing life like.
Sure. And can you tell us, since you mentioned kidney stones first, what has your experience been with kidney stones over time? Maybe how frequently do you get them? Has that been pretty consistent over the years? And what would you say is the biggest thing that's been, impacted in your life because of the kidney stones?
Sure. I do think I had symptoms probably starting at age 4, and took a while to get the diagnosis, and had considerable flank pain until I was diagnosed, and then have had 20 surgeries to remove them. So early on, the management by my urologist was to just only intervene if it was really necessary. I've had kind of sporadically a staghorn stone that was about the size of half of my fist during that period. actually a lot more pain. We scheduled the surgery, so maybe 7 months of consistent pain whenever going to the bathroom. I will go through kind of stable periods for a few years at a time, and then the stone just ends up getting a lot bigger, and there's been an intervention. I've been through PCNL surgeries, percutaneous, something where they have to go through my back. And then I've had obviously ureteroscopy as well. I've tried to kind of change the approach over time to get the ureteroscopy is much less invasive from my perspective. It maybe is less efficient and effective from my doctor's perspective, but the PCNLs really take a toll on me. And so the stones, like I did mention, have been constant. So I have them now, and there have been two particularly big impacts on my life. One is that my childhood dream was to be a diplomat, and I was denied the medical clearance to take that position because of the primary hyperoxaluria and the frequency of these surgeries from the State Department's perspective. The other really big impact was that when my husband and I started to want to start a family, I had a miscarriage, and then the urologist really said that I had to delay starting the family in order to process some of the stones that had been stable in my kidneys, but the fear there was that I would have trouble during a pregnancy.
Sure.
So again, it's kind of this negotiation with the urologist who has to care for me if something were to happen during a pregnancy.
Absolutely. Yeah, two very incredibly huge impacts there. So thank you, Lily. I want to go to Donna now and ask a similar question. So, Donna, coming from your perspective, looking at back and looking at that polling question where you had to pick, the things that had the greatest impact. Why don't you tell us a little bit about your experience?
I'm Donna Case, and I'm from a small town in North Carolina called Robbinsville. We're very small in Europe. But anyway, Joshua passed away with oxalosis, so he was sick most of his life. A lot of surgeries. It's the scar tissue. One of the symptoms that I haven't heard today, Joshua required a lot of blood transfusions, and then he went on into kidney failure, and he had so many stones, but his thankfully were large, and he never pass them, so it was just a lot. But we did have years of where it was kind of normal, and that was very enjoyable. And then after the kidneys actually failed was the worst. That is the worst. That's the pain. His bones broke. If he twisted a lid, heart, it was constantly hospitalization. He required dialysis 5 days a week. He hurt. He couldn't sleep. He cried from the pain. And, I held him when he died. And that's the impact. You never know when it's going to happen. And you face it daily with the pain and sickness and vomiting and just the food. He was on dialysis. Certain foods he couldn't eat, and then the oxalate, he couldn't eat those foods. So it's very hard, and it's hard to say which impacts you because they were so many that impacted him. When I hear their story, I hear Joshua.
And Donna, thank you so much for sharing that. If you don't mind me asking, how long into Josh's journey did he experience the oxalosis and all of that you talked about?
He actually was diagnosed when he was 7 months old. He was playing one day, and we looked, and there was blood in his diaper. The next day, we was at Henrietta Eggleston in Atlanta up Emory, and he had so much surgery, like a 17-hour surgery, and everything had to be redone. He kept continuing to make stones, and they would try to bust them, and he, over the years, that was just common. But now we had several years where the oxalate was still high, but he had pretty normal life, and that was wonderful. We'd have some things, and then when he turned 20, that's when everything went down. That's when, he started, we thought it was the flu and doctored him for the flu. And by the time we got to the hospital, his kidneys had already failed. And he was full of stones. And then, he lived 5 years on dialysis, but it was a hard 5 years. It was just constantly in and out of the hospital and pain. He suffered a lot of pain. That's the worst part of watching it.
It's the pain, sure. Well, thank you so much, Donna. I really, really appreciate you being willing to share that with us. I do see that we have some folks on the phones that have been calling in wanting to share some of their experiences of living with PH. I see we have Becky from California, who's a caregiver of 2 children with PH, who wants to speak to this topic. Actually, I think we're going to have to wait a second to go to the phones there. Why don't we check in? I do also see that we've gotten some written comments that are coming in from those of you that are participating live today. What are we seeing in terms of symptoms and impacts?
Yeah, so to Donna's point, Megan from Colorado, who has PH1, wrote, I was diagnosed with PH1 at 19. I am now 31. The symptoms with the most significant impact to me are stone formation and episodes of pain and spasms in my kidneys and ureter that my nephrologist believes is due to scar tissues from multiple surgeries. I've also had 2 kidney infections, one of which resulted in an ER visit and was quite serious. Mary from Kansas wrote, I have 2 children with PH1. Our daughter was diagnosed with PH1 at the age of 19, with no prior symptoms after CT scan revealed hundreds of stones in both her kidneys. Over the next 3 years, she experienced several serious kidney infections. And we just got one in from Natalie from Colorado, whose daughter had PH1, wrote that the symptom has had the most significant impact on our family is having my 2-month-old baby girl in kidney failure. From that moment on, nothing in our family would ever be the same. Kidney failure is a symptom of PH1 I would not want anyone, let alone a baby, have to go through.
Sure, wow. Thank you so much for those of you that wrote in. That's really, really important to hear from you all and hear so many different voices throughout today. We're gonna come back to our Zoom panel here and maybe ask Brendan, as we've been thinking about some of these symptoms, we've definitely been hearing some common experiences largely around the stones. Is there anything, in your family's experience that maybe is a personal take on something we've heard or maybe something we haven't heard yet?
Sure. Yeah, first off, thank you so much for giving me the opportunity to be here today. My daughter, Claire, who's 9 years old now, was diagnosed with PH3 when she was an infant at around three months of age. So her experience, a lot like we've heard from others so far today. She first had a urinary tract infection, which we thought was just going to be ordinary course type of thing. And then we learned that she had something called hydronephrosis, which effectively is when your kidneys swell because you can't void the urine. And so, of course, the doctors, in looking at that was something that's incredibly not typical for a 3-month-old child. So a number of tests and scans that they at first couldn't quite believe, but saw a number of different kidney stones, including when Claire was just 3 months old, one that was in her ureter causing a blockage and causing an infection. She had all the horrible symptoms that others have spoken about: fatigue, nausea, vomiting, just was incredibly lethargic. And so we had to have an emergency procedure done called a nephrostomy, which is when you put a tube into the child's kidney directly so she can void the urine directly into a bag. And now picture a 3-month-old child. This is not obviously typical. And at the time, one of the typical interventions that would be done would be a stent would be inserted. But there's no such thing as a stent for a 3-month-old child having this type of procedure. This just doesn't exist. The tools don't exist. So very sort of basic procedures, this nephrostomy tube where small child, barely an infant, the bag was as big as she was. And that was done for about 8 weeks before they had to go in and do what Lily was describing, which is a percutaneous stone removal procedure, which happened a bit later. And so all the while we were waiting for a diagnosis of what was going on. So dealing with the acute issues and waiting ultimately for diagnosis, incredible anxieties, as you can imagine. And we got the procedure done. We got the diagnosis with the help of the OHF on PH3, which had just really been characterized at that time. Literally, I think 6 months prior to our diagnosis, thanks to the research that was being done, they were able to tell us what Claire had. And so we were just kind of lapsing into a more normal cadence when bang, the same exact thing happened again in the other kidney for Claire. So literally by the time she was 1 year old, she had 4 different procedures to deal with these stones. And I think that, as all the other panelists have described, all the anxiety as a parent about the future and what may come to pass when there's no very good natural history of PH3 in particular. I think Dr. Milner spoke about the registry. There's maybe 100 different patients in the registry. We don't know a lot about the disease and the progression that's going to take. And hearing Donna's heartbreaking story, other stories, I think really just adds lots to the anxiety about what might come to pass in the future.
Absolutely. Thank you so much for sharing your and Claire's story, Brendan.
Thank you.
So I do think we have Becky from California back here. Apologize for that. So again, Becky is a caregiver of 2 children living with PH who wants to share her children's experiences with symptoms and impacts on their lives. So Becky, are you with us?
I'm here. Can you hear me?
I can. Welcome.
Thank you. I actually have 3 children with PH1.
3 children.
So,
okay.
Yes. So I'll just tell you about the first one that was diagnosed. He had kidney failure at 5 months old. Well, he got sick at 5 months old after being very healthy, almost trying to crawl. He got sick with flu-like symptoms, so I took him into the doctor like 4 times in 11 days, and they kept sending me home saying it was the flu. And I was trying to feed him with a 10 ml syringe like every 20 minutes to get a little bit of fluid in. He stopped breastfeeding. Finally, on the 11th day, I took him in and I said, my baby's dying. I'm not leaving until you figure this out. And we lived in a small mountain town, so they just took labs. Then he was life-flighted to Sacramento, California, and there we found out he had end-stage renal disease.
Wow.
But they had no idea why. So they said his kidneys were already, they said they looked like walnuts. They were calcified.
Wow.
So, and he had never passed a stone that we knew about. And so he was put on the transplant list. He had to gain 2 pounds. He had to get to 16 pounds to get a transplant. Me and my husband were matches, so we had a kidney for him, but it took a whole year for him to gain 2 pounds because he was on peritoneal dialysis because he had not been diagnosed.
Right.
So he was so very sick. I remember one day in the kitchen after giving him his medication, and he threw up again for the 10th time, and it was only like 10 o'clock in the morning, and I slumped down and just sobbed with my baby in my arms because I didn't know how to fix this, didn't know what was wrong. So a year later, he got his dad's kidney, and a few weeks later, they went in to biopsy the new kidney, and it was full of stones already.
Oh, no.
That is when they figured out that it was this rare disease, PH1. So because that kidney had already been damaged over the, already,
Sure.
we had to have a liver, but they waited till he was 5 because he was so sick. He couldn't have another transplant. Waited till he was 5, and he got a liver. And then before that, he got congestive heart failure because of a dialysis issue. They didn't know if it was going to be chronic or acute. He got peritonitis 2 or 3 times from the hospital, and we almost lost him. I had the funeral planned from the peritonitis. It was so bad. Anyway, then he got his liver when he was 5. And at 16, he needed a new kidney because of the damage done to the kidney between those few years before he got a liver. I was able to give him a kidney then. And 6 months earlier than that, my daughter, so then once we knew that it was this disease,
Sure.
the other kids were tested. My younger daughter and older daughter had it. So my 18-year-old, 6 months before my son got his second kidney, she had her double transplant liver and kidney.
Wow.
And so then my third daughter, she is 14, is asymptomatic, and is on a drug study.
Wow.
We are so very grateful for that and hope that she doesn't have to go through what the other two did.
Yeah. Well, Becky, thank you so much for sharing that. I mean, so helpful to hear, although, so terrible to hear, your son's journey over the years. Very fortunate to have such a loving and caring family in you and your husband. So really appreciate your sharing that. We have another caller, Mariella from New York, who's the caregiver of a person with type 3 PH. So I'd like to welcome you. Are you with us, Mariella?
Yes, I'm here.
Welcome. So Mariella, can you share with us?
So my daughter, Alyssa.
Go ahead.
Oh, yes, I'm sorry. Alicia. My daughter, Alyssa, is now 9 years old. She was diagnosed with PH3 when she was about 6, but she first showed her symptoms at age 3. However, the symptoms, which was a UTI to begin with, was found to be from urine reflux. So honestly, to this day, I'm almost not even sure if it wasn't for this urine reflux causing a UTI, if we would have ever even found the pH. She has passed kidney stones, but she hasn't felt them being passed.
Okay.
We're very fortunate for that. But however, when we did accidentally find these kidney stones, because they were looking at her kidneys from the UTI, and there were so many kidney stones that they couldn't even count them at age 3, and there was just like little white dots all over the place on this image. And one of them was almost an inch big, so they had to go in through her back at age 3, hospital stays, to remove it. And after that, some of the smaller ones were getting stuck. They had to go in and remove them, and everything was just a process of elimination. We switched to 2 different doctors in New York, 2 different hospitals, and eventually found ourselves in Boston at the Stone Clinic. And our first visit was an immediate diagnosis and such a relief to finally have someone who knew what they were talking about. But it's just really scary because not knowing for all that time and all those surgeries and what's wrong with my child, and nobody has an answer. Her pediatrician, that she's 9, and they still don't even know what it is. They ask me questions when we go in for a visit. Right. So it's just very overwhelming. So I'm very grateful for that urine reflux that was completely unrelated, because I honestly think to now we would not know that she had it.
Yeah, and I think you had mentioned that all of this has had some impact on her school and social life. Could you share a little bit about that and what was really, has had an impact on her life? What that's looked like?
Oh, absolutely. So she was in the Girl Scouts, and they would do things like go hiking or go overnight camping, and that was just like a no-no. Like, I was so worried about her overdoing it and just needing the extra water, and what if I wasn't around, and then how would they deal with this? And we just weren't prepared for that. And she was still so little, like 5, 6 years old. Every time she goes, even if she goes to a birthday party and she's dancing, she's got to carry that jug of water with her. We had issues at the school where I had to get her a 504 because she would have a substitute teacher, several of them, and they wouldn't let her use the bathroom often. Or, she couldn't bring her water bottle to the gym class. And so it just turns into so much extra little things that you normally don't think about that you have to deal with. At this point, her friends now, they understand she's always got to have that water bottle at her desk, and she's going to take it to every class with her. And if they have a play date, she's, carrying it around. But it's not the norm for a lot of kids. It is out of the ordinary, but she's adjusting now. It's been a few years now that she's had to drink. She drinks a few liters of water every day.
Sure. Well, thank you so much, Mariella, for calling in and sharing you and your daughter's experience. We have one more caller we're going to take on this topic before we go to another polling question that we have queued up for you. We have Arnold from Utah, who's a person living with PH himself. So, Arnold, are you with us?
I am. Thank you.
Welcome.
I appreciate being able to participate. I feel very blessed when I hear about these small children. When I think about my situation, I first started having a lot of kidney pain at the age of 14.
Okay.
And I had my first kidney surgery at the age of 16. About every 7 or 8 years after that, I had a major kidney surgery to remove stones from my left kidney. Now, my first surgery at 16, they removed about a third of my left kidney, and that's where I had most of the problems over the years. My oldest sister, who is 9 years older than me, had her first kidney surgery at 2.5 and had several surgeries over the years and was hospitalized frequently with infection. She died at age 33, and it was at the time of her death, she was at the University of Utah Medical Center that they determined what the disease was.
Wow.
I was 24 at the time and had another surgery, and that's when Dr. Bloomer determined what I had. I was very fortunate to be able to be put on vitamin B6 and 3 to 4 liters of water a day. The greatest limitations I felt was during my junior year of high school, I missed quite a bit of school. Often a lot of pain, but I learned to live with the pain, which was helpful as I would pass kidney stones frequently in between the surgeries.
Were you missing school because of the surgeries, or was it because just we were feeling so terrible that you had to miss school?
It was because I just wasn't feeling good with the pain.
Sure.
Until after that first surgery. And then as I'd passed smaller kidney stones, I just learned to manage those for the most part.
Okay.
Through high school, college, and so forth. One of the things that bothered me quite a bit was with the death of my sister, I had the perception I would not live to be very old. And I had to deal with that as I entered into marriage and told my wife to be, I may not live to be very many years old, but was really blessed. At age 67, 66, I had end-stage renal failure. That's when at Dr. Milder Mayo Clinic and had a double transplant in April of 2013. So I feel very, very fortunate.
Sure. Great. Well, Arnold, thank you so much for sharing you and your sister's stories with us. It really meant a lot. Before we actually go to that polling question, I do see that we've had a number of written comments come in also on this topic of symptoms. So I want to check in with Kim. What else?
Yeah, so just to leverage off the last caller, Deborah from Switzerland, who has 2 children with PH1, just wrote in, her second daughter is often sick and has to go to the emergency room. She's also very tired, which affects her state of mind and well-being. So as we sort of look at those polling questions, we see that other category, and we recognize there is that state of mind and well-being that I think is a current theme. Also, Rebecca from Queens wrote, I was diagnosed at the age of 28, and the next day I went into renal failure. The worst symptoms was the pain of the kidney stones that led to the many surgeries. So I think it really starts to hone in on the variability of the disease and that it ranges from all different types of symptoms, from kidney stones to anxiety to fear and not thriving to be in infancy and things of that nature. So
yeah, absolutely. Really,
it gives you a good scope.
Yeah. Well, thank you, Kim, for sharing those, and thank you all for sharing your comments. We're going to keep collecting those, keep putting them in that form underneath the live stream here today. Even if we don't get to read yours, they will be included in that Voice of the Patient report. So nothing will be lost. I promise you that. So now I want to kind of broaden the discussion. We've started hitting on this already a little bit, But we want to understand, beyond maybe any one symptom or one health effect of your pH, we want to really know what that means in terms of the impacts in your daily life. And so we have a polling question that's going to get us started off on understanding this. So pull those phones back out, go back to that other tab in your browser on your computer. If you're just joining, go to pollev.com/OHF-PFDD. For all of our patients and our caregivers that care, whether you're a family member or a friend of someone living with pH, we'd love to hear your responses to these questions. This one is, what specific activities of daily life are most important to you that you either are less able or unable to do because of your or your loved one's pH? And select up to 3 here. So what are the top 3 activities that are most impacted by pH? The options are A, attending school or working, B, personal hygiene, C, driving a motor vehicle, D, participating in sports, E, participating in other types of hobbies, F, performing household tasks, G, participating in family care and family activities, H, going out, socializing and traveling, or I, some other activity that's important to you that you are unable to do or less able to do because of your pH, or if you're a caregiver, because of your loved one's pH. So please select up to 3 here. So again, we're seeing percentages of responses, not percentages of people who have selected each option. We'll give you a few moments to think about this and select your top 3 responses. All right, so what final responses are coming in here? It looks like the top activity that's mentioned is going out, socializing, and traveling. So we'll really want to understand what it looks like. What made those activities hard or impossible to do? What about your pH, and what are the types of things specifically you were thinking of when you picked that option? We see as a close second here, attending school and work. We've heard about this a little bit already, but want to keep hearing about this. How much school or work did you miss, or was it even a bigger impact than that? We've heard from someone a little earlier that they were unable to even get the type of job that they wanted because of the condition. It looks like all of our different activities here are in somebody's, a number of people's top 3s, perhaps number 3 being participating in sports. But we also see each of the others selected, as well as that option I, other, something here that we didn't list. And so we really want to hear from you about that as well. So think about these. Why did you pick this? What was it about your pH that really drove this impact in your daily life? Please call in. That number is 1-703-844-3231. Share the different activities that have been impacted in your life. To get us kind of broaden this discussion, we're going to come back to our Zoom panel here. And I would love to ask, maybe let's start with Christy. When you were looking at that polling question, Christy, what activities have been most impacted in your life?
I think we've had severe impacts, but I guess first off, I'm sorry, I'm Christy, and I am the mother of Haley, who has pH 3. She first became sick when she was 6, was not diagnosed until she was 12. And I am currently undergoing testing to see if I have pH 3 as well. My 3 options were school, sports, and like traveling or doing things.
Okay.
And I feel like most of them, for the obvious reasons, bathroom use is a constant. I feel like we're in the car for 10 minutes and she's got to go again. So it takes us extra hours to get anywhere. School, she's just always so sick or in so much pain, so many appointments. I would say her freshman year, she averaged going to school 1 day a week. She definitely missed way more than she attended, and that seems to be current. And then, of course, now with COVID, her doctors will not allow her back on campus. So now both of my children have been, stuck with the homeschooling option because they are too afraid of the risks if she were to develop COVID.
Absolutely. So, Christy, can you tell us a little about when you said they could only go to school 1 day a week? What was happening on those other, 4 school days that made it so they couldn't attend?
I will say Haley sleeps an extreme amount. I mean, I thought for a while it was like teenage years or something, but no, she would sleep for days if she could. So she tends to fall asleep in class. And then she has extreme pain episodes. So I would say the day she's not there, it's one of those reasons, or because we're at appointments, which is a constant as well.
Yeah, and maybe just to help us understand those days where she was able to go to school versus not, something tells me that she might not have, it's not like the days that she did go to school were great days. What is, maybe can you, give us what that good day was where she go to school compared to those other days?
Yeah, obviously the nurses at my daughter's school, watch her very closely. They're all very aware of the specific condition. I would say she doesn't get to participate in sports like, I hate to say quote unquote normal kids, but she doesn't anything that takes a chance of her landing on her back or causing any damage to her kidney is a definite no for us. She's huge in cheerleading, but is limited on what she's allowed to do because she can't take any chances of damage to the kidneys.
Sure.
She experienced pain episodes every day in school and often would typically only make it about a half a day before the nurse would call and say that she needed to be picked up. Nausea is another huge thing for her. She'll just run out of class and start throwing up. Just one of her quirks, I guess.
Wow. Well, Christy, thank you so much. I want to go now to Jennifer and ask a similar question. In that list of activities, which ones have been most impacted?
Hi, I'm Jennifer. I have twin boys, Jackson and Harrison, who have PH2. And I would say the most impactful ones to us for activities that they couldn't participate in is I was scared to death to let them go for sleepovers. Especially, there's no way they were going if I didn't know the parents at all. Worried that they would get their amount of drinking in that they needed. And then they have like the whole diet thing adds a whole nother level with the sodium and the oxalate and how much we allow them to consume per day. And, then the medication. And then another thing that impacts us is the sports. We have allowed our kids to participate in the sports, but you will often hear us from the sidelines, drink, you got to drink when you're on the bench. Also traveling, like a lot of times when we take road trips, we would leave in the middle of the night because otherwise you are stopping so much because they do need to go to the bathroom so often from all the fluid intake that, they do over the course of the day. So those were the main things that have impacted us so far.
Yeah.
Right. Is there a particular, example that you can think of where, maybe you had planned, based off of those kind of accommodations, but where, because of the pH, you just weren't able to, actually go along with those plans?
We really don't, we really try to do everything. Like it might be modified, maybe we don't go as far long or, we just have to plan. You have to plan all the drinks to take with you. And is there a bathroom that's accessible? And so, we always try to, much as possible, participate in what we can. It might be modified, like I said, but like a hike or something. We might not just do the full hike. We do part of the hike with a family or something. But I really, really try to not have them miss so much because then it affects them too, because then they feel different. And, we can't do everything because of my disease. And so then it hurts, to see them upset. So we really do try to do as much as possible.
Sure. Really appreciate that. Thank you, Jennifer.
James, so I just had Deborah from Switzerland write in, and to Jennifer's point, she wrote, we no longer have holidays abroad because we don't know what medical facilities are available, but we do know what kind of care our children need in an emergency. And this knowledge and fear control our lives. We also realize that we visit a general practitioner or family doctor. They don't like to treat our children because they are afraid. They don't know enough about the illness and refer us to someone else. So really, very afraid to take any holidays or vacations. And then, Natalie from Colorado wrote, my 13-year-old girl is also dealing with the effects of permanent, significant oxalate deposits in the retinas of her eyes. No glasses or operation will ever fix the damage that has been done due to the overproduction of oxalate she experienced at a young age. She now has to sit at the front of the classroom at school and read with enlarged print. She has to keep finding new ways to compensate for her vision loss. Doctors are unsure if she will ever qualify for a driver's license. So really, you see this with the children. It's very impactful on their school.
Right.
And then we even have adult patients writing as well, that they're impacted trying to get to work and the bathroom break. So we see a common theme.
Absolutely. I see we have a couple of phone callers that also want to speak to the impacts of pH on their and their families' lives. We have Kathy from Rhode Island, who is a parent of 2 pH1 patients. So why don't we go to Kathy and ask her about some of the impacts in her life and her children's life. Ooh, apologies. Actually, sorry, we actually have Pat on the line. So Pat is from New Jersey, also a parent of a child. So apologies for that. Pat, are you with us?
Yes, I'm here. I'm Pat from New Jersey, and actually my son is an adult now, but he was diagnosed when he was 4 years old. And just kind of reiterating what other people have said, that the impact that it had was really difficult when he was little. I mean, he looked completely normal, was physically very active, but so therefore people don't recognize that there really is an issue. He really has a health issue. He really is in pain. He really needs to miss school. You know, I remember teachers, he did play a lot of sports, but coaches and maybe religious instructors, if he missed a practice, if he missed a class, it was like, really? Does he have it's another kidney stone? It's like people don't get it because they can't see it. Or to the other woman's point, who you just read about not traveling to the United States because of the health care. Like, I was in the emergency room often with my son, and doctors or healthcare physicians in the emergency room who are not aware of this disease, they don't want to believe you. They don't want to think you know maybe what's going on. I don't know if you understand what I'm saying, but it really is very, very difficult to get across to other people that your child is suffering, and it's a valid disease, and it's hard at times. It's just very difficult when he was young.
Yeah, absolutely. And you know, was it just explaining the kidney stones, or was it also explaining, you know, those other symptoms that came along with it? Which I mean, all of it is invisible.
Why he might have to go to the bathroom. It was everything. It was the other symptoms. You know, I mean, luckily in school, I had a good relationship with the nurse, and he had no problem carrying around his water bottle. Yeah. But just the fact that wherever he went, he had to have his water bottle. You know, he had to be able to leave the classroom to go to the bathroom. He had to be able to go to the nurse if he ended up with a kidney stone and needed to be picked up from school. Mm-hmm. And it's got a huge impact on your family, because I would go to work and I wouldn't know if I was going to get a phone call that I needed to leave and come pick him up, or if my husband had already gone to work. Mm-hmm. Right. You know, it's impactful in everyday life, and going on family vacations or going on to family events. You know, it just impacted his life so, in that he'd just be knocked down for the count, where he couldn't attend many things because of his kidney stones.
Sure.
Pat, thanks so much for sharing. We often hear from so many families that this is such an inward-bound disease. So everyone looks fine from the outside, but inside, it's a different story. So thank you for sharing those comments.
Yeah, thank you, Pat. We also have David from New York, who's an individual living with PH1, share some of the impacts of this condition in his life. David, are you with us?
Hi, yes.
Yes,
How
welcome.
you doing? Good afternoon. Hi, Kim. It's David.
Hi, Dave.
Hope you remember me?
Of course.
Hi. So I should start with my story. I was diagnosed at the age of 3 in England by Dr. Dan Shore. Mind you, this is back in 1990. I produced my first kidney stone when I was 3 years old. After that, it was mainly, sorry, I'm losing my sense of words. I apologize.
No worries.
Take your time.
Is there any...
After the age of 3...
Go ahead.
Hi, I'm here. Sorry about that.
Okay.
So after the age of 3, mainly I had to get percutaneous surgery to get kidney stones removed. After that, it was mostly drinking a lot of water throughout my childhood, medication therapies, vitamin B6, paradoxin, magnesium, which unfortunately didn't have really good results. After that, I just jump on to maybe 2 years before the age of 10, between 2 and 8, I was very active, playing soccer, drinking lots of water growing up. After that,
is there anything that you weren't able to do as much? You mentioned you played soccer.
I'm sorry?
In your childhood, you mentioned that you had to drink a lot of water and you were able to play soccer. Was there anything that you felt was limited in terms of activities at that point?
It depends. When I was going to, as far as activity went, no, I wasn't limited at all. I was actually, I was very active, very hyperactive kid, but it was very unfortunate. I always had to watch out after a lot of physical activity. If there's any kidney stones that were sitting in my kidneys, I had to be careful. They could always move around, and then before you know it, one of them could move and get stuck in your ureter. And then that would cause, that would be a cause for treatment. So that was always to be something on the lookout.
And how about today, David? What are the biggest impacts you would say today for you?
It was mostly the worry of having to get the severe kidney stone pain that would cause nausea or vomiting. It's very, very intense, and there's almost no medication that can treat it.
Sure.
From day to day, I'm sorry, I'm losing my train of thought for no reason.
Oh, it's no worries. Just any final words on today? What you would say if is there any activity that you're not able to do that you wish you could?
No, currently today. Well, I have to specify. I am a post-liver kidney transplant patient.
Okay.
I got transplanted when I was 27.
Sure.
And I'm currently 34. As far as activity goes, not really. I'm very physically active.
Great.
But I do have to be very careful especially with the projection medication that I have to take.
Sure.
Well,
I really
keep everything extremely clean, especially during this Corona times. I have to be extremely cautious. I do work in the aviation industry, and that's not necessarily a clean industry.
Sure. Well, I really appreciate these comments, David, and for sharing so much of your journey. Thank you so much. I want to bring it back and give a couple more of our Zoom panelists a chance to chime in here. Maybe we can start with Brendan on this topic of activities in daily life that have been impacted. Brendan?
Yeah, hearing all the other panelists and callers in, I think the biggest issue is the disease has just such a negative progression over time. And right, so there's periods of normalcy, but there's this general downward trend where kidney function is likely to be impacted and going down. So the doctors are drilling into you all the time. If you have a stone event, that's going to cause damage to the kidneys. If the kidney gets damaged, the GFR, your filtration rate gets lower, which in turn means you can't filter the overoxalate you're producing. It always just feels like this really big downward spiral. So I think as a parent of a child, you have to be so mindful of that, where even when things seem like they're outwardly fine and normal, you need just extreme caution all the time. So if a typical kid comes down with a cold or gets the flu and maybe they're vomiting, get dehydrated, no big deal. For our kids, that might mean a trip to the ER in addition to make sure that they're getting IVs to stay hydrated, and because otherwise you're going to expose yourself to that negative spiral that I just described. And that just permeates every single aspect of your life when you're making all these risk assessments. So, should your child participate in sports. We heard that come up. Is it going to be okay to be outside playing tennis in warm weather and things? Some parents come out on different ends of that spectrum. Should your child go to that party where some of the kids might be sick and you might be exposed in one way or another? And so it always informs your judgment and potential fears of what might come to pass, knowing that just literally one screw up, one dehydration event could lead to a stone event, which in turn could mean a kidney stone, a blockage, a surgery. And just this constant sort of Damocles hanging over your head based on those really bad outcomes. And knowing it's a long downward trajectory unless there's an actual treatment option here in one way, shape, or form. And many of us the children are taking quote unquote a medication, but as we heard, we're talking about vitamin B6. So this is not bleeding edge stuff. We're talking about citrate and phosphate. These are actually the FDA actually regulates these as food, not drugs, which just really highlights that we really just need something much more substantive for these patients so they can go out and actually live a great, fulfilled life and feel safe.
Yeah. So Brendan, let me take that back to something you were talking about. You were talking about the different ways that people might need to be cautious. What sticks out in your mind in one of those times with your family where you had, feel like something had to be really limited, or you had to, say no to a certain activity?
There's multiple times. Usually it's in the social realm. I can remember just very, very recently, this was pre-COVID, as things were getting a little bit crazy. One of Claire's friends had a birthday party, and the extreme caution that we felt like we had to take, and this was before things got really bad. And so choosing to remove her from that social situation and avoid all those bad things, those are real things that happen all the time.
Sure.
We talked about sports. My wife is a avid tennis player. My daughter Claire she does more drama and music. Great activities, but she's probably not going to work up a sweat in those cases. So we've kind of steered her towards those activities where we feel like she'll be much safer and avoid those bigger issues and just not putting her in that position.
Absolutely. Thank you, Brendan. I want to also check in with Christy. Do you have something to add on this topic of activities of daily life that have been impacted?
To be honest, I just wanted we had a couple callers ago that had mentioned stones in their eyes on their optic nerve.
Mm-hmm.
That is something that my daughter is currently suffering from, and I've been told that there is no operation to correct it and that it will probably eventually take her vision. So I was just shocked, I guess, to hear another caller say that. I've never heard another person mention that particular symptom. And I feel like it has a huge effect on her. Like, my daughter's getting ready to go in for another percutaneous surgery. And she can't be laid flat anymore because of the stones on her optic nerves. It may make her start stroking out during surgery.
Wow.
So I don't know exactly how that's done. Maybe an upright table. I have no idea, but I just thought it was interesting. Somebody else brought up that particular issue.
Yeah. Thank you, Christy. And for that insight. I don't think that's something we've heard yet about the risks during surgery. Want to check in, Kim, what else are we hearing from our written commenters on the web?
Yeah, so Natalie from Colorado wrote that her 3 children with PH1 frequently have the urge to urinate, which interrupts their days at school and when out playing with their friends. Embarrassment when the urge to urinate comes over and over, they end up going in their pants. That's hard on kids. She continues to write, my 5-year-old is still not fully potty trained because she drinks so much water during the day and at night. So that means no sleepovers. Mm-hmm. In addition, with her recurring UTIs, her bladder hasn't been trained properly to let her know when it's ready, when it really is time to go. This is a struggle she deals with on a daily basis. So again, really coming back to, taking away sleepovers and sporting activities because of the constant need to urinate because of the superhydration that many people with PH often have to do. Let's see. So lots of comments are coming in. Keep them coming all day, everyone. And here's another one. This is actually an adult patient, Matthew from California with PH1. The downside to treatment includes the need to frequent bathroom breaks, which can be very disrupting for many aspects of my life, including time-consuming jobs, travel, and road trips. So basically, you see that theme of patients and families not being able to travel, avoid holidays, time off from work and school, and that constant need to go to the bathroom and deal with all the problems that are happening in their lives.
Mm-hmm. Sure. So I see we have a caller who wants to add this topic, and I think this will be the last comment we take on this before we go to our last discussion and polling question for this session, and that's Matthew from California, who's a person living with PH1. Matthew, are you with us?
I am. Hey, thanks. Yeah, I think, and thank you, Kim, for reading my comment, actually, just recently. So hi, everyone. Yeah, I can add, though. I actually had something else to add. So,
wonderful.
Yeah, I just wanted to say I'm a PH1 patient. I was diagnosed, I think, around the age of 1. I had bilateral obstructing stones and went into complete renal failure and almost died at that age, to my understanding. So ever since, I've obviously done everything I can to avoid stones. And I think for me, probably the most debilitating thing growing up was just the, I guess, psychiatric aspect to it. So there wasn't a day, there wasn't a day that went by when I was in high school and college and didn't think about pH and how how it could affect my life and maybe need a transplant, and those things are so scary. So I've never talked about this before, so sorry, it's really hard. But yeah, so ever since I try to cope with it a little bit better. I think I'm very optimistic now with all the new treatments and potential treatments and things. So I'm in a better place mentally, but it's really hard to read about it online and hear all these cases and just think that when is your time going to be. So thank you for the bravery for everyone that spoke. It's really eye-opening to hear all these cases and things. So I really appreciate it.
No, thank you, Matthew, and thank you for speaking to the important topic of kind of mental health. It's we saw a lot of people select that as a top impact in the polling questions. So very important to speak to that as well. So I want to take us to now our last polling question of this session. Again, to get us thinking about this last topic we want to cover here in the morning. So again, pull out your phones, go to that other tab, go to polluv.com/OHF-PFDD. The question we have for you is, what worries you most about your condition in the future? And here again, we want to have you pick up to 3. The options are A, the stress of not knowing how the disease will progress, B, the worsening of severity and frequency of symptoms, C, unexpected emergency room visits or surgeries for stones, D, the need for dialysis, E, not having the energy to go to school or work, F, not being able to live as you want to, G, not knowing if you can support yourself or your family financially, H, the fear of becoming a burden to your family, I, dying at a younger age, or J, some other worry or fear that you have about your pH or your loved one's pH that's maybe not listed on this slide. That is one of your top 3 worries about the future. I know, again, this is a hard one. We're asking you to pick only 3 things, but if you can think about this and pick those which most worry you about your condition in the future. And again, just as a reminder that we're seeing percentages of responses, not the percentage of people. So this is a ranking of sorts. As it stands, it looks like we have a little under a quarter of you, our top worry for the future being the one that is the stress of not knowing how the disease will progress, kind of that uncertainty that we've been hearing about a bit. After that, we're seeing kind of a drop-off for kind of a second tier of worries, which includes dying at a younger age, the worsening of severity and frequency of symptoms, perhaps even also needing dialysis being kind of in that same grouping. Although it's not too far behind that is not being able to live as I want to. But what we're seeing is all of these different worries are ones that are in somebody's top three, with many of them being a fair number of you selecting those. So we want to hear about these worries and why, what specifically about these worries you, given where you are in your disease experience. We actually have a phone caller. Someone's dialed in to speak to this. I'll remind you, you can call in at any time, 1-703-844-3231. Please share with us, continue to add to the conversation around the impacts on your life, but we're broadening the discussion. So if you want to share a bit about your worries for the future, we would like to hear that too. So if we can go to Kathy, we have Kathy from Rhode Island, who's the parent of 2 PH1 patients. Kathy, are you with us?
Yes, I am. Hello, good morning. Actually, it's afternoon.
Yes.
I'm the mom to 2 PH1 patients, one who is 16 and one who is 12. My 16-year-old was diagnosed in 2009, early 2010 officially, after having a 5 by 3 by 2 centimeter stone removed from her right kidney. We have been constantly provided follow-up through Boston Renal Stone Clinic at Children's Boston. Since that time, we are seen every 3 to 6 months, mostly every 3 months. Both of my children, both of my daughters, are B6 responsive, approximately 30%. So we are very hopeful for the future, although there's always that constant stress and worry that in spite and despite drinking 3 to 4 liters a day, being careful with diet, being careful with activity, being compliant with medication, that things could go very wrong. Now, Kate, our oldest, she also had vesicoureteral reflux, and she was carefully followed up until age 4. So when she started having Coca-Cola colored urine episodes, knowing that we had already gone through constant scanning, the pH diagnosis and the stone formation exactly came out at 4.5, 5 years. She had percutaneous nephrolithiasis with a nephrostomy tube placement in, again, early 2010. Addison was actually diagnosed at 3 in 2011, completely accidentally, with having absolutely no symptoms whatsoever. We did an ultrasound and experimental testing, genetic testing at that time, and once they started ultrasounding her in the room, I almost fainted on the floor because we saw multiple stones. Yeah. We knew then that we were dealing with both girls having PH1. So basically, since 2011, it's been constant intake, 3 to 4 liters of fluid a day, vitamin B6, potassium citrate, and magnesium oxide. Both girls were immediately placed on 504 accommodation plans to help with school. Yeah. I come from a nursing background and a school nursing background, so I immediately wanted to bypass any issues with water intake and bathroom access within the school time. COVID, let's talk about COVID. COVID has impacted things. Both myself and my ex-husband have made a decision, along with our daughters, to keep them as virtual learners until January, just as a precautionary measure for their health. But both girls basically every 18 months or so have to forgo ureteroscopic lithotripsy. And we just kind of live it. one day at a time. Kate's kidney function on the left kidney is quite poor. It's only 10 to 15%, but her right kidney is fabulous at like 85%. Addison has full function of both kidneys, and I talk a lot, apparently. We're very blessed, and we have a lot of hope for the future, and her father and I continue to co-parent for the benefit and the proper positive outlook for our children.
So Kathy, can I ask you a question? Given your two daughters' different kind of where they're at and some of their differences and experiences, are your worries pretty much the same for each? Because you had mentioned a little earlier that you do have, despite everything you're doing, that continued concern. What is that kind of burning
I will
concern?
be honest.
Yeah.
Yes, sorry, I didn't mean to interrupt you. I will be honest with you. It's always been my gut worry. I am more fearful for Kate, where her left kidney is not as well functioning. And frankly, there was an underdevelopment of that kidney and a scarring of that kidney, both of which having to do with vesicoureteral reflux and perhaps the PH1 on top of it. So I've always felt that, not that I consider my children sick. They still have a quality of life. They are still living life. Yeah. But I consider Kate to be at higher risk due to the less functioning of that kidney.
Sure.
So I do worry about her more so than I do Addison, although I worry about them equally. Yes. I try not to be a helicopter parent. They've always had a social circle. They've always had friends. We've always had sleepovers. I've always said, I don't care who you bring home as long as I have enough food in the house. So that part, we really, and my ex-husband and I, we've always traveled with the kids. Yeah. Of course, we always have to think about the bathroom stops and the water intake and where's the bathroom. But that just kind of comes with like basic parenting.
Yeah. Well, thank you, Kathy, so much for sharing so much here. It really has been valuable. Want to come back here to our Zoom panel and go to Christy and then Jennifer here on this topic of worries for the future. Christy, can you start us off?
Sure, James. I think my concern would be that, Haley's 16, she'll be 17 on Halloween. And probably about a year ago, roughly, she started suffering with extreme suicidal issues that she started expressing, thank God, to the social workers at the ERs when we would go. And strictly because her comment is that she doesn't want to wait to die. Like she feels like, she never knows what's going to happen. Surgery, she's going into surgery number 16 when we do surgery this time. And so I think that's a huge fear for me as a mom. Like now I'm afraid to leave her alone and really watch who she's around and what their influence is and things like that.
Sure. Thank you so much, Christy. And Jennifer?
So I just wanted to add, one of my biggest fears right now is my kids are 12 years old. These next 10 years, they're going to be in their teenage years. They're going to go to college at some point during that time. And I just fear that they're going to rebel. They're not going to drink that, the amount of fluids they need to every day and, just blow it off, because they're know-it-alls at that age. And, if there's not a medication that's truly going to help this disease, then I'm always going to have that fear. So just having something that is actually going to improve their lives and not have to worry so much about their future and the progression of this disease and if they will ever need transplants. I think it's key that we have to have, something that's going to help them besides these over-the-counter, vitamin type drugs.
Mm-hmm. Yes. Great. Well, thank you all. And thank you to our whole Zoom panel for sticking with us this whole time period and sharing so much of your own stories. We're going to end here with some of the comments we've received in writing on this topic of worries and fears for the future. So, Kim?
Yeah. So we're getting flooded with comments, so keep them coming. Lisa from Australia writes, I was diagnosed with PH approximately 18 months ago. My husband and I undertook genetic testing prior to planning a family because I couldn't fathom passing on my disease to another person. Last year, I gave birth to my son. I could not love another person more. Now, as a mom, I worry that my good health will not continue forever. I worry that I won't get to watch him grow up. I worry that he will have to see me in pain and suffering. Carliam from Belgium. My daughter was diagnosed with PH1 at 2 months old. Since she suddenly went into complete kidney failure, she almost died. We live in constant fear that something could go wrong again with our daughter or that she will reject her liver. Matthew from California, PH1 as well. The worry about future symptoms can be very debilitating. It can be hard times to suppress those fears. And it just continues. The fear between patients is across the board. Debbie from Switzerland, we live with fear daily and wonder what will happen next. Recently, I noticed how I was always make sure to have a full tank in the car because I never know when the next emergency will occur. The hospital stays are a test. Our family is pushed to the limits with fear, worry, fatigue, having to make decisions and handling everyday life. Our 6-year-old recently said to me when she went to do an MRI, "Mom, is this my life now? Do I always have to go to the hospital if I have the slightest pain and maybe stay there as well?" So these comments are coming in from the United States, around the globe. We've had patients from Nepal write in, and the same thing over and over is fear about the unknown.
Absolutely. I really want to, again, thank everybody who has submitted a comment. If you wanted to speak, you wanted to call in, or you want to share something in writing, while we're about to go on a lunch break here, we do want to remind you that we're going to be coming back in not too long this afternoon and continuing the conversation and really building on it and trying to understand, what treatments you're using, where there are still needs and what you're looking for from future treatments. So still a lot to cover, a lot of opportunity to hear your voices. So please stick around. At this point, thank you for working through with us to really understand what it is to live with PH. We're going to take a 30-minute break and come back at 1 p.m. Eastern Time to resume this session today. So thank you.
Thank you, everyone.
Hello, my name is James Valentine. I'm here with co-host Kim Hollander, and welcome back to the externally led patient-focused drug development meeting on primary hyperoxaluria. As we come back from break, we have a video that we'd like to share with you to give you a glimpse into the life of 3 families living with PH. Let's take a look.
I was not diagnosed until my late 30s, and that was because my oldest brother Steve got very sick. They figured out that he had primary hyperoxaluria type 1. And so Steve ended up passing away, and then Eric, he had a liver and kidney transplant after his diagnosis, but unfortunately he just passed away a year and a half ago.
So we first found out about the boys having primary hyperoxaluria when Jackson was actually an infant. My biggest fears at this point were, how is this going to affect their longevity of their life, their quality of life?
The hardest part was trying to figure out why I was able to do everything that my friends were doing, yet kind of still struggling with all the things that I was behind the scenes, kind of having to answer those questions around why are you taking medicine, why are you eating different foods. Never really wanted to sleep out at friends' houses in case something happened and needed to go to the doctor.
It's an evil disease, and it affects not only the patient, but I think the emotional impact on caregivers is really difficult too.
Primary hyperoxaluria is a rare genetic cause of kidney stones and progression to chronic kidney disease, so the patients may have many procedures to take care of the kidney stones over their course of their life. It also requires a very large amount of fluid intake. This is a lifelong disorder, but at this time there's no true treatment.
I've passed, I think, 2 or 3 kidney stones in the last year. I've had 4 surgeries in the last 2 years, and it's become a much harder thing to manage.
A typical day in our household is getting multiple drinks ready for the boys to take to school, 80 to 90 ounces a day.
We have to drink milk in the morning, then we have to drink, I drink lemonade, he likes apple juice. So basically we do that till the end of the day. With dinner we drink milk.
I mean, when you look at someone who has primary hyperoxaluria, you would never know.
You know, I had all the symptoms, and not to know what my future and what my family's future was going to be was very scary.
My hopes in the future for the disease is that one of these potential pharmaceutical companies' medication is going to work with very minimal side effects and help patients live a longer, healthier life and not have to worry about having a kidney or liver transplant.
Early diagnosis so that other families won't have to go through what my family went through.
My hopes for the boys is that there will be something that will make it a lot more of a minimal effect on their life without the fear of kidney stones or fear of kidney transplant in the future.
Thank you and welcome back. So now we're at the part of our agenda where we're going to expand the conversation from this morning. For those of you that were with us, you'll know that we really explored what it looked like, what it felt like to live with PH, the symptoms, health effects, and impacts on daily life and worries of the future. Now we're going to build on that and really try to help all of us understand what are the different approaches to treatment that this community employs to try to help treat, manage, and just live with their condition. And so if we can show our discussion questions in this panel, what we're going to be asking all of you to think about, and again, to call in, write in, answer polling questions about, are what are those different things that you're doing to help manage your PH symptoms, or if you're a caregiver, your loved one's symptoms. We're going to explore those treatments a little bit more than we did this morning, where we heard a lot about a lot of those different interventions, and not just medications, but also surgeries, transplants, even things beyond that. We have diet, we heard about water intake, other supplements, more holistic approaches, even lifestyle modifications. Everything's on the table here for this session in terms of the different types of treatment approaches we want to hear about. And we're going to ask you about how those treatments actually work in treating the most significant symptoms of your PH that you so well educated us on this morning. And then we're also going to, as Dr. Thompson said, no treatment comes without some trade-offs or some side effects. And so we do want to explore what are those most significant downsides to the treatments that you have available to you now, whether that is a side effect, whether that's other burdens like recovery time or the amount of time and travel it takes to receive an intervention, or whatever you yourself might consider a trade-off or a downside to one of these treatments. And then we're going to come back at the end of the session and think about the future. And while we all would want a cure for PH, knowing that we want, before we get to that cure, that there may be a pipeline of therapies, and we know that that pipeline is starting to fill out. What is it that you're looking for from treatments that would be coming down the pipeline? What does that ideal treatment look like for you? In other words, what would be meaningful for you if a treatment was able to provide it? And then we'll ask, when considering taking a new treatment, what factors are important to you? So you'll get to tell us your preferences, what you're looking for, your treatment goals for the future. So to get us started on this topic, we have another panel, our second panel of the day, with Christy, Neil, Sarah, Michelle, and Jennifer, who are going to share their experiences with treatments and their hopes for the future.
My name is Christy Ouimet, and my 17-year-old daughter Molly and 9-year-old son Matthew have PH1. Molly was 3 years old with her first kidney stone, but we didn't get a diagnosis until she was 6. The only form of treatment we had was to watch and wait and to increase her water intake. Every 6 months, we met with a nephrologist and had labs done and an ultrasound of her abdomen. If she had symptoms of passing a stone, it would be addressed then. Molly passed stones occasionally as a child, but some were too large and needed surgery. Most of her surgeries were by uteroscopy, and a temporary stent was placed. She had missed a lot of school over the years and could not participate in activities. We rarely traveled, but when we did, we always stayed near the hospital, and we carried her medical information with us since most people did not know what PH1 was or how to treat it. When I was 20 weeks pregnant with Matthew, it was confirmed he also had PH1. When he was 28 days old, an ultrasound showed he had both kidneys loaded with stones. We were told to watch him closely and have everything rechecked when he was 6 months old. However, he went into end-stage renal failure at 5 months old and had to be rushed to UCSF Children's Hospital in San Francisco. He spent 2 weeks inpatient getting stable and had a hemodialysis catheter placed to clean his blood of toxins and oxalate. We were discharged to begin our treatment in the outpatient pediatric facility in San Francisco, 50 miles away. Matthew was placed on the transplant waiting list for a liver and kidney, and he had a G-tube placed to help give medication and nutrition. He also had a peritoneal dialysis catheter placed so that fluid would stretch his abdomen so that it could be large enough to receive adult-sized transplanted organs. Peritoneal dialysis was 7 days a week at home for 4-hour sessions. They explained that Matthew needed adult organs because he had such a large oxalate burden that if he had pediatric organs transplanted into him, the oxalate would destroy those organs. We continued this schedule, 4 hours of dialysis in outpatient clinic and an additional 4 hours at home every day for 2 years. Matthew got his kidney and liver transplant when he was 2.5 years old. Due to life-threatening complications, he spent a lot of the next year in the hospital. Organ donation saved my son's life, and it is a beautiful gift that is never taken for granted. However, Matthew has had a lot of transplant-related health issues and will continue to face many of these challenges the rest of his life. Matthew is now 7 years post-transplant. He still relies on his G-tube for medication and to assist him in achieving his fluid goal of 3 liters a day. He has monthly clinic appointments and labs. He's on dozens of medications and will continue to be on most of these medications for the rest of his life. He has had to be homeschooled due to severe weakened immune system, and he recently had a biopsy of his kidney, which confirmed he has new complications and health issues, and he will need another kidney transplant in his future. When Matthew declined so fast as a baby, we knew this was a possibility for Molly. We didn't want to use the same wait and see treatment plan for her, and we wanted to avoid transplant if we could. We traveled across the country to meet with specialists and tried to get her into clinical trials. Molly started to decline as we waited for these trials to begin. She spent more time in the hospital and out of school. We were desperate for a treatment, and it was a race against time. In January 2020, Molly was admitted to have 2 stones removed that were over 1 inch in size. The doctor operated through her back to get to them. Her kidneys were starting to shut down, and in March of 2020, she had to start hemodialysis 6 days a week for 3 hours each day. In June, we were finally granted the opportunity to get an investigational medication which has helped lower her oxalate numbers over the past few months, and she currently only needs dialysis 3 days a week instead of 6. For the first time, we started to think we had options for Molly that we didn't have for Matthew. Was it possible to keep her liver if the medication continued to work? Then on August 31st, 2020, we received an offer of a liver and kidney for Molly. After careful consideration and discussing with the doctors, surprisingly, we chose to pass on those organs. We have witnessed how well the medication is working on Molly in reducing her oxalate in just a few months' time, and how the quality of her life has improved, not having to be in the hospital every day on dialysis. We also remember how difficult it was for Matthew and all the complications we had with his double transplant. We felt Molly was healthy enough to pass on these organs at this time. This is life-changing on so many levels. If she does not need a liver transplant, she can find a living donor for a kidney transplant. And by not needing a dual liver and kidney, those organs can go to someone else and save more lives.
Hello, I'm Neil Marklew and I'm from Cannock in Staffordshire, the UK. As a PH2 patient of 56 years, I'd like to talk about the different types of treatments, and when it comes to treatment for PH and oxalosis, I've been there, done that. For the first 15 years of my life, it was still unknown as to what was causing my kidney problems, but I was treated with magnesium hydroxide, something which is no longer used, plus a high fluid intake, i.e. 4 to 5 litres per day, every day as soon as I was able to. This helped wash the excess oxalate out of my body instead of it depositing as renal calculi. On the whole, this medication was deemed a relative success as I only needed 2 operations for kidney stones plus a kidney removal in those 15 years. The operations were very invasive, leaving 2 large scars on my abdomen and each time a several weeks stay in hospital. The 400-mile round trip to London every 3 months for 12 years was very difficult for my parents. I received the diagnosis of PH2 some years later. My 1 damaged kidney plus other medication, including different citrates over the years, was all I needed to prevent from further renal damage for over 20 years. However, in December 1994, my remaining kidney was showing renal calculi again, and despite lithotripsy to break up the stones, which unfortunately was unsuccessful due to their position, my renal function declined very quickly and I had to receive emergency peritoneal dialysis to save my life. The next few months were a very traumatic time, as now we were no longer managing or treating PH. It was now all geared around managing and treating oxalosis. Within 3 months, I initially had COPD. However, after just a short time, it proved to be inadequate at removing oxalate. So at the age of 31, I was now looking at spending the rest of my life relying on a machine to clean my blood in order to stay alive. Remarkably, within 6 short weeks, I received the call. A suitable transplant had been found for me, the Holy Grail. My life would change forever and I wouldn't be totally reliant on machinery to live. A transplant is the ultimate gift one human can give to another. It is not a cure for PH and or oxalosis, but it is the next best thing available right now. I have received 2 transplants so far, and on each occasion I had to have 8-hour sessions of hemodialysis for the first 14 days post-transplant in order to give the kidney the best chance. My first transplant, plus a high fluid intake, gave me the opportunity to do what I wanted, and I was free to carry on as any normal person would be. This treatment was very successful, but at the age of 47, I was faced with end-stage renal failure again. Back on hemodialysis, I undertook a one-man research program to find out which dialysis routine would be the best for oxalate removal. The research showed that hemodiafiltration was better than the usual hemodialysis, and that the longer sessions would be better for oxalate removal. However, these bring other complications which involve closer monitoring than usual. Me and my partner agreed with my consultant to do 8-hour nocturnal sessions 5 days per week at home. This would be the best treatment available for oxalate removal and to clear the other poisons in my blood, i.e. creatinine and urea. Annie and I received the necessary training and to prepare for this dialysis regime, and I started home hemodialysis in July 2011. Dialysis is very invasive and changes everything you've done previously to manage pH. For example, no more high fluid intake, as the patient is often put on a fluid and dietary restriction to prevent fluid overload and the breathing implications that goes with it, and to manage potassium, phosphates and other mineral levels, which often requires further medication to manage. Despite this, the oxalosis continues to cause me many problems, so finding a better treatment or medication that truly would change everything and give pH patients a genuine hope of leading a normal life is something that has driven me for my entire life and has always been the main factor when I've endured the many x-rays, ultrasounds, CT and MRI scans, along with the urine and plasma samples for research over the years. Thank you.
Hello, my name is Sarah Davis, and 2 of my 4 children have primary hyperoxaluria type 2. My daughter Giovanna was diagnosed with PH2 at age 1, after months of vomiting, seizures, and intense pain. Never would I have guessed this baby, who was so ill, was suffering from a mass of kidney stones that would eventually cause ureter blockages and hydronephrosis. Severe infections were to follow. Giovanna had to be treated with an antibiotic that was so toxic it had to be injected slowly over several hours as not to poison her. The doctors delayed surgery as long as possible since the surgical tools they would use were bigger than her tiny little kidneys. Eventually, 19 stones were removed from my 2-year-old little girl. Sadly, more have reappeared and continue to build. Shortly after Giovanna's diagnosis, my newborn Logan was also diagnosed. I didn't feel strong enough to watch another child go through this. I felt panic that overshadowed his first few precious months. Jovi had a G-tube placed so we could keep her hydrated by syringing water into her little belly every few hours. She would say, "My tummy hurts, Mommy. It's too full." I recall worrying about water intoxication, but I was equally afraid of oxalosis and organ failure. Each night, I would spend the last few hours of Logan's day offering bottle after bottle as he would begin to doze off. This was the only way I was able to get him to drink 20 ounces every hour as I rocked him to sleep. I remember a spring Sunday at St. Mary's Hospital in Rochester, Minnesota. Giovanna had surgical stents placed into her kidneys to keep hydronephrosis away. She had entered a cycle of vomiting and seizures. When she arrived at the hospital in the middle of the night, she was so dehydrated that it took 17 pokes, 2 hours, and the life flight crew to eventually insert the IV into her foot. Her cries were soul-piercing. The more I read about this horrible disease, the more terrified I became. Would my children really need a transplant in the next 30 years? What happens if there were no kidneys available? What if the dialysis couldn't keep up and calcium built up in their eyes, bones, and their heart? All I could think about were the awful things that could happen. I knew I could never be strong enough to witness them. The school nurse makes certain they each get 60 ounces of water during the day. which results in several bathroom trips. This also affects their learning time in the classroom. Because of her G-tube, Giovanna won't wear a two-piece swimsuit or do any activity that requires her to be on her stomach for fear her G-tube will catch on something and get pulled out. This has happened before. She doesn't like it when the tube is visible through her shirt. She sometimes feels broken and because of her disease and becomes sad. This in turn makes me feel guilty as if it is my fault. We modify their diet to reduce the oxalate in their urine. Excess oxalate will bind with calcium, causing the kidney stones. Chocolate, rhubarb, spinach, and nuts are all high in oxalate. It is hard to explain to a child why they can't have chocolate cake or candy at a birthday party while their sisters can. Being the parent of a kid with even a moderate case of PH2 is waking up every day to kiss them and hand them a bottle of water at the same time. I sometimes fear they will begin to think my love comes with an ulterior motive. It's tracking every ounce of water they drink because now they have to drink and it must start as soon as they wake up because you know if you get behind, it's hard to catch up. I'm reading everything you can to find out if lemon juice or apple cider vinegar are truly natural stone remedies. It's mixing powdered phosphorus and water daily to help reduce the oxalates. It's hoping your child will not wet the bed at a sleepover. Jovi is an active 10-year-old who has adjusted to her disease. Logan, now 9, has had sharp crystals in his urine, and when he sees blood, we know it's time to increase his fluids. For us, there will always be the lingering question about the slow but certain impact of oxalosis and the invisible attack on its victims over time. Thank you all for being a part of the solution.
Hi, Mom. I love you.
Giovanna.
I love you.
Hello, my name is Michelle Lederhose, and both my husband Matt and I live just outside of Boston with our family. Our son Luke started 3rd grade and turned 9 in September, and daughter Brooke is 6 and just started 1st grade. Both children have PH3. When Brooke was 7 months old, in the fall of 2014, she was hospitalized for a week with a severe UTI. Recognizing the severity of her infection and questioning why a baby would have a UTI and show so many shadows on an ultrasound, we were immediately referred to see a urologist in Boston Children's Hospital. It took a year to confirm that Brooke in fact had primary hyperoxaluria type 3, the rarest type of a rare disease. Brooke was immediately put on a course of treatment to balance her urine and make it as clean as possible. You can imagine trying to get a toddler to take medication, let alone 2 times a day. She had good days and bad days. The hardest part was when I still to this day call excessive fluids. Getting a strong-willed child like Brooke to drink average fluids is one thing, but having a target goal with a sippy cup and a toddler is another. Brooke would have urinalysis and ultrasounds every 3 months at Boston Children's for her follow-up. At one of our follow-up appointments, Luke was ultrasound, and they found that he had stones. After further testing, was diagnosed with PH3 as well, no other symptoms. Here we are, 2 kids under 4 with a serious rare disease. Talk about uncharted waters for our family. There have been 2 kidney stone incidents that I will never forget. The first was with Luke. He was recently diagnosed, and we were having a normal night at home. He said he felt some pain. We had him lie down, drink some water, and all of a sudden he went white and his eyes rolled to the back of his head. He went limp. He was out cold and we couldn't get him up. So we called 911 and they took him by ambulance to the hospital with lots of inconclusive tests to follow. Doctors believed he experienced traumatic pain and his body shut down. 1 less stone on an ultrasound is the only thing that got us to this conclusion. The next episode was a couple years later with Brooke. While traveling for work, I landed to about 10 voicemails from daycare and family. Blood was in Brooke's urine and she was in pain. Sure enough, after a visit to Children's, our strong girl had a stone that was passing. It was at this point we knew we had to take this even more seriously. We needed genetic testing to confirm the diagnosis and be eligible for trials down the road. Today, Luke and Brooke are both in public schools and on a formal medical plan, so all in the building know that the kids need their water bottles with them at all times. They may need frequent bathroom breaks because of the water and the volume that they intake. We work closely with guidance counselors, school nurses, and teachers in the building to ensure that everyone's aware. Like most kids with the disorder, Luke and Brooke don't want to be called out or feel differently about the disorder. At home, both kids take Magnate each morning and at night. They also take hydrochlorothiazide, a medication often prescribed for high blood pressure, yet proves to keep our kids' urine clean, and we pray for no long-term side effects. Brooke also takes a gigantic potassium citrate pill each morning. I remember it breaking my heart the first few times she could have choked on it, but the liquid was just not staying down and upsetting her stomach. While they understand that these medications are a part of their daily routine, it's always a worry. I call hydrochlorothiazide pill a pee pill, which we make sure the kids take early in the morning because it does make them urinate more frequently, and if we take it too late, it'll just be disruptive to their day. When they play sports, they are likely to go through almost 48 ounces of water during a game. I feel like their body now craves the hydration. Currently, the kids get ultrasounds and meet with Dr. Baum and a urologist every 6 months. Additionally, Brooke has to repeat a VCUG for her kidney reflux. She seems to have outgrown it, but it's always a worry that if she did need a correction, it would disrupt the normal path for her stones to pass. We would love to see a miracle medication to help the kidney and liver break down the oxalate. The goal would be to reduce the need for daily medications that likely have long-term side effects we don't even know about. And hydration will and should always be important. We hope for a medication that is least invasive and something that could be given at home. One pill that could do it all would be ideal. Thank you.
Hello, my name is George Tidmore and I'm 16 years old. I was diagnosed with primary hyperoxaluria type 1 at age 8 when I presented with 8 kidney stones. My wish for new drug therapies would be those that help treat excess oxalate production so that I can maintain my kidney function, those that improve my kidney function, and also a drug that would reduce the water drinking requirement and the frequency of taking a medication. I'm supported by my family and would like to introduce my mother, who will tell my story.
Hello, I'm Jennifer Lawrence, George's mother. As George described, he was diagnosed at age 8 with primary hyperoxaluria type 1. In retrospect, he had likely experienced kidney stone events prior that were misunderstood as bouts of gastroenteritis. But his first recognized kidney stone occurred when he was unable to urinate as a stone was blocking his urethral meatus. His first treatment was a urethral myotomy performed under general anesthesia, which involved actually cutting the opening of the urethra to remove the kidney stone that was lodged at the tip of his penis. When the anesthesia wore off, it took 2 large physician assistants to hold George down and remove his hands, which were protecting his surgical site, so that the urologist could apply some soothing lidocaine. Very soon after recovering from this difficult surgery, he presented with stones obstructing both kidneys and had hypokalemia, a blood potassium level dangerously low at 2, with systolic blood pressures in the 210 range and diastolic blood pressures in the 110 range, and an elevated creatinine. We knew something was very wrong. He was admitted to our local hospital. During that short stay, a pediatrician tried to treat his hypertension with a diuretic, furosemide, or Lasix, which would have risked further lowering of his already low potassium and further aggravating his obstruction. We refused the Lasix and were able to get George transferred by ambulance to a pediatric hospital 3.5 hours away, where George had the first of several procedures involving stents and laser lithotripsies to rid him of these stones. As soon as the stents were placed, his blood pressure promptly normalized. Stents were placed initially to open the ureters and allow passage of urine from the kidney to the bladder. After the stent placement, then the following procedure involved using laser lithotripsy, in which an adult-sized tube was placed through the penile urethra under video and each stone was blasted. The lithotripsy procedures would last over a couple hours each time. The pediatric urologist told us that George would be very sore since she was inserting and passing tubes for imaging and for laser lithotripsy in and out of the small urethra, recently cut from the first surgery. She told us that he would have pain with urination and would pass blood clots for several days. And as predicted, after each urinal procedure, the initial post-operative urination attempts were painful for George. We learned that playing Chopin nocturnes would help George relax, which would help him urinate. After each intervention, he promptly returned to school, but used the faculty bathroom because the bloody clots might have been frightening to the other children to see. Once his urine cleared of blood, which took several weeks from the last procedure, we were able to perform a 24-hour urine to determine the diagnosis. Since receiving the diagnosis of type 1 primary hyperoxaluria, George was able to get up to the initial 3-liter water drinking recommendations quickly. But drinking this amount of water every day is not easy. It took daily planning to help George reach his goals. If he struggled, we changed the water drinking plan to help him overcome the challenge. For medications, George has used pyridoxine or vitamin B6 and potassium citrate several times a day. The potassium citrate causes constant acid reflux, for which he takes additional medication. George's kidney function was compromised at presentation, and with pubertal growth, his kidney function has reduced so that his estimated glomerular filtration rate is under 60. We are concerned for his future and want to do what we can to help preserve his kidney function, avoid oxalosis, and transplant requirement. We are hoping for a medication that can protect him from that course. Recently, he entered a drug research trial. For this study, we traveled monthly to our study center, requiring 1 day of travel each way, such that George missed at least 2 days and sometimes 3 days of school every month for the initial 6 months of this trial. In addition, he collected monthly 24-hour urine collections and had monthly blood draws for the study and received the subcutaneous study drug. We are very willing to travel, miss school or work, perform these evaluations for the chance to participate in a trial. We are also willing to risk side effects, including allergic reaction, paradoxical stone formation, and other intolerances if this medicine would lower oxalate production, help George preserve his kidney function, and prevent oxalosis. Thank you for listening.
Wow, thank you, Jennifer, and to all of our panel 2 panelists for being so willing to share your treatment experiences, but also really to dig deep and tell us what it is that you're looking for in future treatments. And that's what we want all of you to do with these questions that I went over a little bit before, but really to explore the broad range of what your experiences have been with different treatments, both what has worked well, what maybe has not worked so well, any downsides, and then we're going to come back at the end to really explore what it is you're looking for from a future treatment. If you have comments about any of these, we really encourage you to call in. You can dial in at 1-703-844-3231. Again, that's 1-703-844-3231. We'll get you in the queue. We'll be able to hear about your experiences, have a little discussion with you. To get us started off on this topic, though, we have a couple of polling questions that we want to go through. So if you've just joined us this afternoon, you weren't able to join this morning, we're asking all of our patients and caregivers to pull out their phones, open up a tab in their browser, go to pollev.com/OHF-PFDD. That is displayed on your screen right now. You'll be able to follow along with this final set of polling questions we have you in this session here on treatment approaches. So this question is, we want to ask you, are you using any of the following to manage primary hyperoxaluria? Select all that apply. Here we're focusing on medications and dietary supplements. We'll have other questions about some other approaches. So here, thinking about all of the medications you use, the options are A, prescription medications, B, ureteroscopy to remove stones, C, percutaneous you'll have to help me out here on this one. Percutaneous, it's the third option there?
Yeah, I did.
Nephrolithoptomy or surgical removal of stones, sorry about that. D, extracorporeal shockwave lithotripsy, sorry about this, or ESWL, E, dialysis. F, over-the-counter medications. G, medical or recreational marijuana or cannabidiol or CBD. H, dietary or herbal supplements. I, antidepressant or anti-anxiety medications. J, other medications, or K, if you're not using currently any medications. So please select all of those different treatments that you use to manage your pH, and please select all that apply. As a reminder, you're seeing percentages here of responses, not the percentage of people who have selected each. So again, this is these bars represent kind of a ranking. So we'll give you a few moments here. I see results are still trickling in, but as it stands, it looks like the top type of medication that's used are prescription medications, including vitamin B6, diuretics, baclofen. After that, we're seeing the ureteroscopy, sorry about that, to remove stones, and then F, over-the-counter medications as the third highest. We are seeing usage of all of these different approaches to treatment that are different medications, including some that are a little more rare, like antidepressants or anxiety medications, and marijuana and CBD. And we have a few people that are reporting that they're not currently using any medication. So, we certainly want to hear how these are working for you, whether you feel that you're getting some benefit from these, maybe you're not sure. You can also tell us, we're going to be asking about the downsides of these different treatments. And for those of you that aren't using any medications, we'd love to hear where you're at in your kind of disease journey, maybe why it is you're not using medications, what factors went into your decision to not currently be on any of these things. So with that, we're going to move to our second question. So beyond those medications and supplements, we have some additional approaches to managing your pH that we want to know whether or not you use them. So the options here are A, exercise, B, physical or occupational therapy, C, drinking extra fluids, D, that low sodium, potassium, calcium, or animal protein diet, E, cutting down on foods high in oxalates, F, complementary or alternative therapies, G, counseling or seeing a therapist, H, other treatment approaches that haven't been listed, so either on the last slide with medications or here on these other types of management approaches, or I, if you're not currently doing anything, you're not taking any medications, you're not using any of these approaches, please select I. And again, select all that apply. So results are still trickling in here. As it stands, we're seeing that the highest management approach taken by the participants today is drinking extra fluids. While we've certainly heard about that a number of times come up in the morning session, we would want to hear what that actually looks like for you, how, what your approach to that is, what that's meant for you, maybe when you're able to comply with that more or less in your life, if you've noticed any differences in your pH and its symptoms. We see after that cutting down on foods high in oxalates. And so again, diet being also coming up again in D, another top management approach with that low sodium, potassium, calcium or animal protein diet. So really interested in understanding, how well diet is helping in terms of reducing the burden of your disease symptoms as well. We're seeing exercise, counseling, and other treatment approaches being used by a good amount of people. Some more, less commonly used are physical and occupational therapy, as well as some complementary or alternative therapies. Definitely want to hear about those, just because they're not, if you're one of the few people who selected that, we want to hear from you. Call in, write in, tell us what you use those therapies for, how well they're working. And we don't see anyone reporting that they're not doing anything to help manage their pH. So one more question for you at this point. So thinking about all of those, all of these different types of treatments, we want kind of collectively for you to answer, how well does that current regimen control your overall condition? Your options here are A, not at all, B, very little, C, somewhat, D, to a great extent, or E, not applicable because I'm not using anything. So think about this, of these different categories, pick the one that most closely resembles how well you're your or your loved one's current treatment regimen is controlling their overall condition. Give you a moment to think about this and get your response in. All right, so we'll let these final responses come in here, but what we're seeing is the majority of our audience today is saying that these treatments help somewhat in controlling their overall condition. About a third of people are saying it actually controls their condition to a great extent, and about 10% saying it does so very little. No one has reported that their current regimen does nothing for their overall condition. And no one, again, is not using anything. So there's no one that said this was not applicable. So for those of you that said somewhat or to a great extent, we want to hear about where these treatments are helping you, and that's where I want to start this discussion. So we'll save some of the downsides and maybe things that aren't working so well for just a little bit later. Let's start with what is helping, since a number of you have reported that you're getting some benefit from the things that you're doing. Maybe we can start here with Beth. Beth, when you were looking at those different treatment options, what are the things that, out of whether that's medications or something else, that you view as most valuable?
So I'm Beth. I'm from Concord, New Hampshire, and I'm a PH1 patient. And I had two siblings who had PH1 as well who have passed away. What's been most helpful is I am B6 responsive. So I'm blessed to be in that group of PH patients, which is a minority of us, but has worked really well for me. Also, the hyperhydration is something that has been a regular part of my life, probably even from before, well, actually not probably, actually from before I got diagnosed, and may well have kept me on the right path until I did get diagnosed. I did for a while take potassium citrate, but have a hard time tolerating it. And since I've been on medication and was diagnosed in 2003, it's really important that any therapy I use is a long-term therapy. So that really, I dropped off of the potassium citrate because it really was problematic for me.
Sure. Thank you so much, Beth. Maybe hopping over to Dan. Dan, when you were looking at those questions, anything that sticks out to you as what out of the total existing kind of standard of care regimen is most valuable?
Good afternoon. First of all, I'd like to say thank you to everyone from the FDA and the OHF for taking the time to do this. Really appreciate it as a parent of a 7-year-old PH1 female patient. My name is Dan Wallenberg. I'm from Columbus, Ohio. And we have been fortunate as well to be B6 responsive with our daughter. So right now we're not experiencing too many issues and things are going very, very well for her.
Sure, and when you say that B6 responsive, was there something that you noticed kind of upon initiating B6 that let you know that that was working well or doing something?
Sure, we were diagnosed at 6 months with a failure to thrive, and taking her repeatedly to pediatricians and emergency rooms, and finally getting some reaction when we initially were ill, could not get anyone to believe that we were sick, that she was sick. Finally, after vomiting blood, she was diagnosed with issues at a children's hospital here in Columbus, where a treating physician just happened to think, hey, I heard about this disease. Let's test for that. And she tested, and her numbers indicated that she was a middle-aged man about ready to have a heart attack. And so they were extremely responsive at that point to try and find out what was going on. And after many meetings with nephrologists and kidney specialist, B6 was attempted, and she almost immediately started to regain and started to thrive again.
Is that in kidney function or kind of what parameters?
Kidney function, and just she, as I've heard throughout the day, infants just became limp and became almost lifeless and became almost unable to function. And she almost immediately, upon starting B6 and Citric A combination, started to thrive and regain and started to regain kidney function. And her numbers went back to relatively normal where she is today.
Wow, that's great to hear.
Yeah, and James, I just heard from Megan from Colorado who has PH1. She wrote, I currently take B6 and is responsive to it, fortunately, and have not had any challenges taking it. This has reduced my stone formation greatly. So most of my managing for my pH for the last few years has been managing periodic episodes and monitoring oxalate levels, blood pressure, kidney function. I also drink a lot of water and generally try to manage my overall health through diet, exercise, and sleep. So there is, for patients with PH1, about 33% of the patients will be vitamin B6 responsive. So this, based on some of the comments we're already hearing, this seems to be right in line.
Yeah, and we love to hear, when something is a common experience, we love to hear about that and hear what that has personally meant for you. I know every patient's journey is a little different, and getting some benefit from something might look a little different than it does for someone else. So please do keep on writing in. Also invite you to call in. Again, that number is 1-703-844-3231. It actually looks like we have a caller. We have Sarah from Minnesota, who's the caregiver of a PH patient. Wants to talk about some of the treatment approaches using over-the-counter medications that her child has tried. So, Sarah, are you with us?
I am. Can you hear me?
Yes, welcome.
Hi. Yeah, I'd like just to talk briefly. My daughter was diagnosed with PH2 back in 2006. At the age of 1, her first kidney stone event was when she was 10 and a half months old. And took about 8 months or so to figure out what was going on and what that diagnosis actually was. And during that time, we were prescribed a variety of different medications, of which included, I think, the vitamin that we've talked about, as well as the Citric K, Fosnac, as well as the hydrochlorothiazide. Today, she is considered very stable at the age of now 15 years old. She continues to take the Fosnac, which is considered an over-the-counter medication. So even though we are prescribed that medication from her doctor's team, unfortunately, because of how it's classified, it is not covered by insurance. And this, for some of us, can be slightly cost concerning just because it's not covered by any insurance company. We've fought insurance over it. We've asked for exceptions to that formulary status, and we've been denied that over time, indicating that, of course, your insurance company wouldn't pay for your Benadryl, which is also over the counter. But I feel that this is obviously a very different situation. But unfortunately, that's where that's at.
Yeah, so Sarah,
that medication.
I was just going to ask, just to put a little bit of what you were saying into perspective for us, because obviously there's so much background you could possibly give on your children. But when you say that they're now stable, are you talking about in terms of kidney function, or have you noticed a change in stones or in symptoms even? Kind of tell us a little bit about what that looks like.
Sure. So for my daughter, she has, early on in her disease, she had many stone events. We've had multiple surgeries over the years to remove those. Luckily, though, for her, as of her last appointment, which was just back in August, she's continued to kind of stabilize in terms of her stone growth or formation hasn't been very rapid. She's got normal kidney function, She continues to be thriving in that regard. So we kind of have put her in kind of a stable category, although we know that that can change very quickly with this disease. We are constantly, watching for signs and symptoms that something has changed, knowing that it can do that very rapidly.
Yeah, and when you say, fairly slow stone formation, what is that for, what does that mean? What would you say the frequency?
I'm sorry, can you repeat that?
Yeah, you were saying that now in the kind of the current state, her kidney stone formation is fairly infrequent. I was just wondering, could you maybe put like a number to that for us?
Yeah, so she had her last stone removal surgery about 3 years ago now, and so since that point, oh, hello?
Yep, you're here.
Still here.
Oh, okay, sorry. Since that point, we haven't had any additional stones to have to remove or that we've seen in her ultrasound that we do on a yearly basis.
Wonderful. Well, thank you so much, Sarah, for calling in and sharing that experience, or really experiences. It's been very valuable for us to hear, and appreciate the comment that, just because something's available doesn't mean you will necessarily have access to it. So thank you so much. I want to come back here to our Zoom panel and still focusing on this comment of what seems to work best or work well. Maybe we could go to Jana and ask you that question of that, treatment regimen that exists. What has worked well or worked best? Oh, you're on mute. Oh, Jana, you're on mute. Oh, there you go.
Good evening. I'm Jana Leon Maurice. I'm in England and I have PH3. When I was worked up to my diagnosis, I was put on the pyridoxine, the vitamin B6. I was given the evacitrate. I was given all kinds of things. One by one, the pyridoxine obviously didn't work. The evacitrate upset my stomach, so I stopped taking that. Someone actually remarked about diuretics, and then I remembered, yes, I was taking those, but I realized I was actually allergic to one of the ingredients, so I stopped taking those. So actually, I don't take any medication. I just drink water and I watch my oxalate level of the dark green leafy vegetables and cut down on red meat, and that's basically it. And do the treatment, does what I do work? I don't know, actually, because I still get stones.
Yeah.
I went 4 years without any stones, and then suddenly I had a kidney full of stones. It took 3 hospital admissions to remove them. Then within a year, I was back with more stones. So I honestly don't know whether what I'm doing helps me at all, to be fair.
Right. Yeah, but you continue in hope that they do. Yes.
Naturally.
Yes, of course. Well, really appreciate that, and we're going to definitely explore more about these different downsides of treatments. But appreciate that, Jana. Currently, you're kind of keeping up with hydration and diet. So thank you for those. Maybe we can go to John again on this, trying to round out this topic of has there anything that's been particularly useful, beneficial in your treatment regimen?
Hi, my name is John. I'm 29 years old. I'm from New Jersey. I was diagnosed with PH1 at the age of 4, and I was not responsive to B6.
Mm-hmm.
So growing up, I was taking polycitrate, K-Phos, and hydrochlorothiazide. And I suppose they, and of course with the hyperhydration, I suppose they helped with preventing me from, having many episodes of staghorn stones. But ultimately, by the age of 27, I was in end-stage renal failure. So on May 23rd of 2019, I received a liver and kidney transplant. And I'm doing well now. But that's ultimately what it came to for me. I spent a year on dialysis 6 days a week.
Wow.
Wow.
And when you say you're doing well now, are you stone free or just manageable stones? What does that look like for you?
Once I went into kidney failure, I didn't produce kidney stones anymore. When you're in kidney failure, you don't really produce much urine. Your body is just retaining all that water. So since my transplants, I think I may still be at risk of forming stones again, but I haven't had any of those issues now.
That's great.
Yeah, wonderful to hear. Thank you, John. I do see that we have written comments coming in on this topic of things that have been helpful.
Yeah.
Kim?
So Mira from Israel, who has PH1, wrote, I felt I was on a dark path, and I started raving about life and thinking that I did not have much time left to live. Many times I was depressed, but hid. And most of the time I tried to help myself by music. By the way, I'm a musician, singer, and violinist. Now, and after the journey with a new clinical drug treatment for over a year, I feel I am lucky and will not experience the tragedies I thought of before. I feel like I have found my health back and life, of course. And we have a second comment about a clinical trial from Amy from Arizona. My son was diagnosed with PH1 when he was 9. I was offered the opportunity to get him into a clinical study and accepted. We travel quite a bit to participate, but his oxalate numbers have gone down tremendously. I see a look of relief across my son's face. I also hear it in his words. I would do anything to keep my son from living a life with a double transplant. The news of his oxalate numbers decreasing has been so welcoming and positive. It has been wonderful to have a small patch of hope since the study has shown these recent results. This is inspiring to hear.
Absolutely. And thank you again for everyone who's called in, everyone who's been writing in. Please keep those comments coming. Reminder that comment box is located right under the live stream on the OFHF webpage that you're on right now. And of course, you can continue to call in at 1-703-844-3231. Now we're going to broaden the conversation. We've been focusing on what has been working well, but we know that treatments do come with downsides, and sometimes treatments also just are not as effective for everyone. So we're going to start to explore some of those different experiences. And to start us off on that, we do have a polling question for you. So if you can pull out your phones, go back to that tab. Again, you can keep this open the whole rest of the program. After this, we've got one more question a little later for you, so you don't have to do anything, but just keep this open and you can answer the questions as we move through them. The question we have for you right now is, what are the biggest drawbacks of your current treatment approaches? So thinking about everything, whether it's medications, the surgeries or transplant, those other types of management approaches. What are the biggest drawbacks from your perspective? And we are going to ask you to try to pick the top 3. The options are A, they're not very effective, B, high cost or copay, and they're not covered by insurance, C, limited availability or accessibility, D, the number of pills or medications or volume of it that's needed per day, E, side effects of those treatment approaches, F, it requires too much effort and or time commitment, G, some other drawback that we don't have listed here, but is one that you view as one of the biggest drawbacks to your current approaches, or H, if this is not applicable to you because you or your loved one are not using any treatments. So again here, think about what are the top up to 3 biggest drawbacks of all of those different treatment approaches. And as a reminder, we're seeing the percentage of responses, not the percentage of people. So this is a ranking type display we're seeing here. So we're going to let these responses keep trickling in here. As it stands, the number 1 biggest drawback that we're seeing from our audience today is the number of pills or medications or volume needed per day as the top drawback, followed by the fact that they're not very effective, and perhaps the third of this group being it requires too much effort and or time commitment. So we would love to hear from you. Have you call in, tell us, which therapies are you referring to here that, it's the, too many of them a day or too much of them a day that aren't very effective, that require too much effort and or time commitment. We'd love to hear about what it is and what that actually has meant in your life, the fact that they have these drawbacks. We are seeing, though, that after that, we're seeing the high cost copay, the therapies not being covered by insurance, so some access issues being a drawback, side effects being a drawback. Really everything that's listed here is in a good number of people's top 3 biggest drawbacks. So we really want to spend a fair amount of time here as a group having you share what those actually are and what those mean in your life. And so if we can come, actually I see we have a caller in who wants to speak to this. So why don't we go to the phones here first and go to Sarah from Iowa who has some experiences to share. Sarah, are you with us?
You bet. Mm-hmm.
Well, welcome. Eager to hear what you have to share.
Well, I just wanted to add to the thing about the insurance coverage. This disease is so rare, you really have to fight the insurance companies since they don't cover phosphorus, and we rely on that. It's technically a vitamin and sold over the counter, so they won't cover it. And there's no exception. The same with my daughter's G-tube. To ensure she gets enough fluid, we've had to have the insurance company, we've had to fight them to get a G-tube that they would cover. They still don't. So luckily, we're able to it's low enough cost, we can pay for it. But it's because it's not needed for food and just water and fluid, they do not cover that because it's not considered necessary for life, I guess. Sure. So there's that. We also have been to amusement parks where we've had to dump out. We've had Jovi and Logan's medicine mixed up in a big 2-liter jug, and we've had to dump it out and then just go back and out through the door to come back into the park because you can't take fluid in there,
Sure. Wow.
or you can't bring your own drink in, and those sort of things. So you can realize are really affecting your life daily.
Sure.
Other people don't even need to think about.
Yeah, that's something we've not heard yet. Really, the fact that needing so much hydration, the traveling with that amount and actually getting into certain things. You think about going into any kind of sports arena or something like that. You can't have any opened container, going in. So thank you for sharing that, Sarah. Really appreciate that insight. So I want to go to our Zoom panel. Amanda, I don't think we've heard from you yet. Maybe you can help us out on this topic of, when you were looking at that polling question at those different biggest drawbacks, what stood out to you and why is that?
Can you hear me okay?
Yeah.
Yes, we can.
Oh, yeah. Hello, everybody. My name's Amanda. I'm actually from a little town in the UK called York. Not New York, but actually Old York. Now, our son Alfie was born prematurely. He was born at 25 weeks, and although the signs and the symptoms were there from birth, the prematurity masked a lot of that. So he had, both of his kidneys were covered in nephrocalcinosis, which is one of the symptoms of very premature babies. And it wasn't until he was about 2 that he passed his first stone. Now, since we got the diagnosis, he has only been on one particular treatment, and that is potassium citrate. We're not offered any other treatment, although I am aware from speaking to other members of OHF that there is other things out there.
Sure.
Now, Alfie's had numerous surgeries. He's had lithotripsy that doesn't work on his stones. He's had the procedure that goes into the back. That didn't work either. And he's had a few where he's had the scopes when he's had stones stuck. But listening to everybody's story today, we feel quite lucky that Alfie's one of those that maybe suffers from PH2 mildly. Now, going forward, we tend to give him lots and lots of fluid. I must admit, we only give him about 2.5 litres a day. We try to encourage him to be active. He plays football with his friends at school, but he's also quite a lazy child as well, and likes to play lots of video games and computers and stuff like that. So as a family, we do try to encourage the activity side of things to get things moving. But medication-wise, the only one that we've had is potassium citrate. And it is something that I'm quite interested to hear, because Alfie's never, ever been stone-free. So he's currently got 2 stones in each kidney, and he has done for the last 4 or 5 years. He's not had any surgery over the last 3 years. Everything seems very stable at the moment.
And how long has he been on the therapy? For how long?
He was diagnosed at 3, so he's 12. So he's been on potassium citrate for 9 years.
The whole time, okay.
Yeah.
Sure. Well, thank you so much, Amanda, for sharing. I was wondering, with the rest of my Zoom panel here, if anyone has, on this topic of greatest downsides, greatest trade-offs that could be maybe something not working very well, or maybe actually a side effect or some other negative consequence. A quick show of hands of anyone that maybe has something that hasn't come up, or you have a personal take on that you would like to share. Any takers from our Zoom panel here? If not, okay, we'll a little bit of peer pressure here. It's always good.
I was going to jump in as well.
So let's have Jana and then Beth, and then we're going to come to Kim. I guess it sounds like we've got some
I'm exploding over here, so thank you for sending comments. Jana?
I don't know if I'm missing the point a bit, but I think for me the biggest downside is the fact that I would just suddenly be in agony when I don't even realize I have a stone. And I would just need to go to the hospital. And my husband's been very unwell, and I actually had to drag him out of bed at 7 o'clock in the morning to take me to the emergency room. And it's things like this, that it's very scary as one gets older. How will I be when I'm older? Will I, if I don't end up, on a trial or having something that helps, in another, I'm 67, so, I mean, how many more I have to go through this? And at the end of the day, every anesthetic is risky.
Yeah.
So, but to be fair, there are so many sufferers that are in a much worse position than myself. And that's really come home to me today. I've been listening all the way through today, and it's heartbreaking how, PH1 sufferers, PH2 sufferers, I've got it really easy. I think I'm very grateful. It seems I have it very easy considering.
Every experience that we've heard today is truly one that deserves attention and deserves treatment approaches. So, what you just shared actually is very helpful. The fact that there's, the way that these acute kind of attacks or pain, the pain comes on so acutely, and you have nothing to, prevent those situations, and they are so critical that, it's urgent and requires that kind of attention. Just to hear that from you, really, hits home. How often has that happened for you, Jana, where you kind of have needed to go to the hospital, you've had that kind of pain that you need, medical attention for?
Many times. Many times. Sometimes I know I have a stone, and the doctors will say, we'll arrange a CT scan for you. And I end up being an emergency before the appointment even comes around. That's happened recently. And so, the last one was a few months ago. I just woke up at 7 o'clock in the morning with pain and wondered what it was. It didn't take me long to realize what was going on, and with the vomiting. And that's a new sign. This has only been going on in the past year, that I would actually vomit with the pain. I never had that before. And, you know, there's nothing you can do except, you know, run for a doctor because you just can't do anything else. Disruptive and very worrying. And I guess my family are used to it by now, but I'm sure, you know, that my sons get a text message from my husband, you know, Mum's in hospital, kidney stone.
Yeah.
Wow.
Well, thank you, Jana, for sharing that. Beth, I know you had maybe under a little bit of pressure there, said that you do have something to share, but you know, everything is valuable, whether you may realize it or not. I promise you, everyone's experiences, and I'm saying this to everybody who's on today. Please call in, write in. You may not think that it matters, you know, that experience that you had, where you had to wake your husband up in the middle of the night to take you to the hospital, but I promise you that it does. Everything that we've heard today has helped evolve our understanding of pH, and you know, so please keep the comments coming. So go ahead, Beth.
Yeah, I mean, first of all, I want to say that Jana probably, I respect her bravery a lot, having been, since I was a child, until I was diagnosed and went on B6, in that situation where she was, where it would just hit out of nowhere and be, you know, when she says very painful, it's debilitatingly painful. And so I really commend her bravery and her, you know, her willingness to try to work through it. And as far as the downsides to treatment, I think what I want to make clear to the people who will be reviewing all of this is that the treatments that are available now, there's not a great one, you know. The hyperhydration has its downsides. I have a very demanding job, yet I'm up all night with having to go to the ladies' room and having to keep hydrated, which, you know, doesn't seem like a huge deal until you're trying to struggle through something with no sleep, or the dietary restrictions. It's not a healthy diet. You know, you have to avoid green leafy vegetables. Like, what is that, right? So that you know, there are other effects of these dietary restrictions. So that can kind of, when I was very strictly following the diet, I found I was very lethargic. The nausea of taking B6 or taking potassium citrate, again, you know, in the middle of the day, I'd want to throw up while I'm trying to be an attorney, you know. And these are all things that I think affect, I hear from everybody. I think and then the fear that Jana talked about, like, am I going to get smacked with a kidney stone, you know, tomorrow? I missed my sister's wedding, you know. I had to suffer through exams when I was in college and law school, worrying about, am I going to get through without it all of a sudden interrupting those kinds of things. So I think the downsides to all of the therapies so far is just, it is incredibly disruptive to everyday life. And I'm blessed to be B6 responsive, but that doesn't mean, you know, you know, also have access to be able to hydrate. That doesn't mean it isn't incredibly disruptive. And for people who haven't found a therapy that at least gets their oxalates down, it's terrifying too.
Yeah, hearing about those real impacts, you know, of, you know, the treatments, you know, that you were describing, right? That those are real, and that's what is really helpful for us to understand. So thank you so much, Beth. Amanda, you want to chime in here?
Yeah, I just wanted to say, because in the UK, we have quite a lot of conflicting information. So for a lot of families that are probably based here, OHF has been absolute paramount in us finding out more information and things like that, and meeting other families. Now, one of the issues that I raise continuously with Alfie's doctor is the diet side of things. And I've heard it brought up quite a number of times throughout today. The only thing that we actually stop Alfie from really eating is rhubarb and spinach. But when we talk to his doctor about it, his doctor encourages us to allow him to just continue normally with food. and not to stop certain things, because I read that it was anything that was pulled out of the ground was high in oxalates and things like that. And it's just, we just get really confused on what's best for Alfie. You know, we're listening to the doctors here who, you know, are not actual experts. I don't mean that horribly, but they do rely on quite a lot of people from the Mayo Clinic to give their information and stuff. But when it comes to the diet, I do worry that maybe he's eating more than what he should be eating.
Mm-hmm.
That makes sense.
Sure. Yeah, hearing, you know, it's not even clear exactly what to follow and what not. Really appreciate that, Amanda. Yeah.
So I'm going to shift gears a little bit. I just want to thank everyone for the comments. But I sort of wanted to dive into this a little bit deeper. So we have Kae-sung from Korea, who has a son with PH1. He writes, my son is now 9 years old and was diagnosed with primary hyperoxaluria type 1 at the age of 3 months. He had a liver transplant 3 years ago when he was 6 years old, and he has been on hemodialysis for 3 years after that. He was waiting, and still is, waiting for a kidney transplant. Oxalate is still detected in his blood tests, and his teeth are weaker than other places, and it seems that it is affecting the jaw and permanent teeth. Even if he has a kidney transplant now, I am concerned that the remaining oxalate in his body will damage his kidneys. And then as we continue, we have Valerie from Washington, whose child has PH3. The current treatments affect our lives the most. Extra hydration is hard to manage in my child, as well as constantly monitoring his food to ensure it is low sodium. If he doesn't have enough hydration, his urine will become tea-colored, and it is worrisome. My child currently takes high doses of HCTZ, low sodium, low oxalate diet, and hyperhydration. However, his 24-hour urine still shows his oxalate very high. Continuing on, and they're just coming in so rapidly. So I'll share one more.
Absolutely.
So this is Carlian from Belgium. She wrote, my daughter was diagnosed with PH1 at 2 months old since she suddenly went into complete kidney failure. She almost died, followed by 2 years of hemodialysis and many more months of hospitalizations, 30+ surgeries. She had a liver transplant at the age of 1 and a kidney transplant at the age of 2. She had multiple complications.
Wow.
So I think this is very, very deep, and the spectrum goes from, you know, what Jana calls mild, and I wouldn't call that Jana mild, 19 surgeries, and I always look at all of our patients from around the world who are living with PH, and you are all warriors. And I think we minimalize some of our side effects and things like that, but what you endure on a day-to-day basis is just incredible. And so we thank you for so many comments.
Yeah, and we've got some callers who have gotten into our queue here to speak to this as well. So if we can go to Christy from California, caregiver of 2 patients, and she wants to speak about their need for treatments and the burdens of trying to get those treatments. So Christy, are you with us?
Yes, I am. Thank you.
Yes, welcome.
You know, life with 2 kids with PH1 is complicated enough. And but when you throw the COVID pandemic in it made it a lot more challenging for us. It also seemed to be about the same time that our daughter really declined to where she needed dialysis. So with our son having his transplant 7 years ago, he has a very complex medication regimen that he needs to be on, and very immune-compromised system.
Sure.
So his care is very specified with how we have to deal with things. But then having to be in California traffic with our daughter going to dialysis made things very challenging, especially with limiting who can be there and who can be in the hospital. When our son was in one wing of the hospital and our daughter was in the other, and we couldn't go back and forth. We had to have one parent with each.
Wow.
It was very challenging. Then you throw in, so my husband left his work so that he can help me at home care for the kids. And we also have a 15-year-old son who, does not have this disease, but we still have to take care of his needs. So the juggling act is very challenging. And with my husband not working, that adds in some financial difficulties as well. So it's not just finding the medication and finding treatment, but it's also getting to these life, helping appointments and making sure that their care is covered in a very challenging time.
Sure, I can't imagine that. And I mean, you hit on a really important point that I think has been spoken to, but maybe not directly, which is just the caretaking burden, the amount of time it takes to stay on top of all of the care, but then these appointments and, of course, COVID making everything in the world more complex, but when an individual is immunocompromised, that's, so much more difficult. We've heard about how many people in this community are living post-transplant. So Christy, thank you so much for sharing all of that. Looks like we also have Kyle from New York, living with PH3. Would love to hear what you have to share about treatment experiences that you have. Kyle, are you with us?
Hey, I'm here. I'm Kyle. I spoke earlier on the first panel, and I suffer from PH3. I just wanted to kind of share my thoughts because I think it's been extremely interesting to hear everyone's perspectives on their experiences or their child's experiences with the disease over time. I think one thing that has become clear is that everyone's situation is always changing, and it's extremely fluid. And I think the medications and the regimens that people are taking often work for certain periods of time, and then their bodies change and their experiences with the disease change. So for me, that was certainly true throughout my childhood. My condition was controlled for a really, really long time. It was almost as if I didn't have PH. I basically had no kidney stones for 6 or 7 years and was just taking my medicine and things were working. And then I got older, my body changed, and that has been a completely different experience for the last couple of years. It's seen a lot more changes to my diet, to my medications that I'm taking, as well as the fact that I've needed multiple surgeries. So in terms of kind of things that I would be looking for and things that I think it sounds like a lot of patients are on a go-forward basis is, one, having a better sense of kind of when those changes are going to be happening and understanding why they are happening and kind of figuring out whether or not there truly is a medicine or something that can control it in the long run.
Sure. And Kyle, can you tell us a little bit about, the changes that you made to your treatment regimen? You mentioned that you were on, a set of some medications that were keeping you stable, but that you did make changes to try to keep up with the changes your body were going through. Can you just maybe describe that a little bit?
Yeah, definitely. I think a lot of people have kind of touched upon this, but the fact that taking medicine throughout the day and the scheduling around when you're taking your medicine is extremely difficult. So as I got older, I had changed sort of the amount of doses I was taking. So when I had started taking medication, it was 3 times a day. That went down to 2 times a day at one point during my life. I switched from liquid medication to pill form because it became increasingly easier as I got older to take pills. But the medications that I've taken, I switched from chlorothiazide to chlorthalidone, which is supposed to be a stronger pill, probably 2 or 3 years ago, and still haven't seen the efficacy of that one in particular. And I think sort of as my diet and everything has changed in terms of kind of continuing to focus on low sodium, when I was a kid, I couldn't eat chocolate, I couldn't eat spinach and all those different items that people have kind of listed. And then at a certain point during my journey with primary hyperoxaluria, they thought that the diet wasn't as important. And so a lot of those foods were introduced to my life. And now I'm starting to think that I need to go back to that stricter diet that I was following as a kid in order to try and control the production more.
Sure. That's very helpful. Thank you so much, Kyle, and your willingness to share all of that. I want to check back in on these kind of treatment failures, treatment downsides, this kind of broad topic we're on. What's coming in through the written comments?
Yeah, so we have Govinda from Nepal just wrote, I am 33 years old and was diagnosed with PH1 this year after being in kidney failure and on dialysis. There is no good treatment or knowledge for PH here in Nepal. I can only have dialysis 2 days a week. There's no lab work to follow the oxalate levels. They only do kidney transplant here, and I cannot afford it. Here in Nepal, I have no hope. There's many that go on. Deanna from London writes, I was only diagnosed in 2019 with PH1 at the age of 57 after a double kidney transplant in May of 2019. My kidney function improved after the transplant to 50%, but gradually deteriorated to as low as 13%. But over a year on it, it is now at 18. So my worry would be that the function deteriorates further. And we're seeing a theme on lots of families, and here's Mira from Israel wrote, I have two brothers. I lost my older brother in 2008 due to PH. The claim was that during dialysis, the oxalates went up to the heart and hurt him. He was 35 when he died in the operating room after the surgeons finished the transplant. In addition, I have another brother who went through a painful journey with the disease until he had a liver kidney transplant. And since then, he is healthy. But every day he takes a large amount of medication. He has difficulties of a different kind. Absolutely. So I think people are feeling this from around the world, and the stories are just, the comments are flowing.
Yeah, absolutely. And keep those comments flowing. I'll do a pitch to keep submitting written comments through that comment form, and also to keep calling in. That number is 1-703-844-3231. If you haven't had a chance yet today to share your experience, we want to hear from you. There's no right or wrong answers to any of these questions. You're experts in your experience, and that's exactly what we want to hear about. Next, I see that we do have another caller in the queue. We have Brett from New York, who's the caregiver of a PH3 patient. So, Brett, are you with us?
Yes, good afternoon. Thank you very much to the FDA and all, the doctors and scientists and drug companies that are working on this. It's pretty clear listening to everyone's story that there is really no true cure right now, and nothing is really working except for a select few with vitamin B6 sensitivity. Our story had major challenges at 6 weeks old in trying to define a rare disease or figure out what was going on with our child. And we were misdiagnosed twice, and we were told that our son was going to die with two unrelated diseases. So the education of the doctors and scientists along with the treatments is so important here. Yeah. Looking back at, when our son was a baby, basically the 24-hour urine collections of catheters turned into stents now that he's in his 20s, post-surgery. We've had double-digit surgeries on our son, and it's just a major burden not only on him but the entire family, two working parents, the economic cost, the quality of life, the mental anxiety. Similar to someone else earlier, he wouldn't go for a sleepover when he was younger because he was worried about urinating in someone's bed because of all the hydration issues. He also didn't want to go to sleep at night because he thought he wouldn't wake up because he was going to die. So the anxiety and the therapy that was needed there, this disease affects so many different things in different people. The concoctions of the medications. So to kind of summarize, obviously we're keeping the urologists and the emergency rooms very busy. The personal and economic costs are way too high. We just must get another treatment or a therapeutic of some sort to help more patients. We're not getting enough patients a better quality of life and a better treatment. And once again, just want to say thank you. I'm beyond grateful to everyone that's working for this cause to help all the patients around the globe. Thank you very much.
Yeah. Well, we're thankful for you for calling in, Brett, and sharing all of that. It was all very well said. So now I want to take us to our final kind of discussion of the day. We've spent a lot of time talking about the current treatments, the things that you've tried, whether you've stuck with them, whether you're still using them, some things that live with you, like transplants. We've explored what's worked well, what's not maybe worked well, or maybe we don't know. And we've talked about some of those downsides. But this is the part of the program we get to look towards the future and have you tell us what you're most looking for. And again, while we all want a cure for this condition, we're kind of looking at what might be coming before that in the pipeline, and what is it that you are ideally looking for from a next treatment. That could be, a wide range of things. Again, there's no right or wrong answers to any of this, but what would be meaningful for you if a treatment could provide it for you? And so to get us started, we're going to go to our final polling question of the day. Pull those phones back out, go to that tab, go to pollev.com/OHF-PFDD, and let us know for this, short of a cure, what outcomes are most meaningful to you in a future treatment. And here we'd like you to select up to 2. So this may be the toughest question of the day. We saved it for last, but a very important one. The options are A, slowing the formation of kidney stones, B, completely stopping the formation of kidney stones, C, regaining strength and energy, D, lessening pain, E, improving kidney function, F, decreasing need for superhydration, G, decreasing urinary tract problems, H, stopping disease progression, I, letting me be able to eat whatever I want, or J, some other outcome that would be most meaningful to you in a future treatment. Again, please select up to 2 if you're a person living with PH, what it would be most meaningful to you. If you're a caregiver, what would be most meaningful to your loved one. So we'll give you a few moments to think about this and pick up to 2 answers. All right, while final results are trickling in, again, we're looking at the percentages of responses here. And so in terms of essentially rankings, what we're seeing is the number 1 ranked outcome that would be most meaningful of top 2 outcomes would be completely stopping the formation of kidney stones. That is certainly number 1, followed what was clearly number 2 is stopping disease progression. And then number 3 is kind of a clustering of 3 things, which is improving kidney function, slowing the formation of kidney stones, and decreasing the need for superhydration. We do have some individuals that have selected decreasing urinary tract problems and letting me be able to eat whatever I want as a top 2 treatment outcome that would be most meaningful. And we also have a number of individuals who have selected other. And so really, this last piece, we want you to call in, we want you to write in, we want to know why you picked what you picked. Tell us out of this list, or maybe something we forgot to include on this list, but what outcomes are most meaningful to you in a future treatment, of course, short of that cure, which is something we all want. So I see we have a caller that has called in on this topic. Let's start with her. Natalie from Colorado is a caregiver of multiple PH patients. What are you looking for future treatments?
Hi. Yeah, thanks for taking my call.
Welcome.
So I asked my 2 teenagers who are living with this disease, and then I have a 5-year-old as well, living with primary hyperoxaluria type 1. And for them, it was being able to decrease the hydration intake. It's certainly a burden for them to have that constantly on their mind as well as on mine, nagging them of what they've been able to drink and keeping track of that. And secondly, a simplified medication routine with 3 kids with this disease. I have over 20 medications, 2 shots, and things that I'm trying to keep track of, when's it due at the pharmacy, and, is that one out of refills? Do I need to call the doctor and get them to refill that? Sure. It can definitely be a burden to try to keep track of all of those medication refills and keeping them dispensed correctly and all of that. So for me as a caregiver, having that simplified medication routine would certainly be a benefit to a future treatment.
Sure. No, that makes a lot of sense and, really well said. So thank you, Natalie, for sharing that. again, this is a perfect example. There's no right or wrong answer to this. Whatever it is that would be helpful to you, help make management of your pH just a little bit easier, that's exactly what we want to hear. I'm going to go to our Zoom panel here, and before we let you all go today, ask if any of you would like to share what you're looking for from future treatments. Maybe, Jana, do you want to start with this? Oh, there you go.
I've been listening to a lot of information that's been broadcast recently about the different drug companies, and I got very interested in the Dicerna research, the Phiox, and through the Mayo Clinic, they directed me to a doctor in London, and I went to see him, and I was really waiting to ask about this research. And he actually asked me, would I be interested in a clinical study? And I said, Phiox 2. And he said, it's Phiox 4. And I said, yes. And so I left there on cloud 9. I was told the study would start early this year, but because of COVID-19, who knows really when it will start. But for pH3, this is something new. And the treatments is said to silence the gene that creates the oxalate.
Sure. So
It's a miracle.
Yeah, so that's very exciting. What would you hope personally to get out of that or any future kind of treatment? What would represent something that's meaningful for you, Jana?
Well, a cure would be utopia.
Yes, we're with you. What short of that cure, though, if you had to say?
Short of that cure, I guess anything that can lower the production of oxalate, because ultimately that's why I grow stones.
Yes.
So anything that could lower the oxalate,
absolutely,
would be great. Anything. I would try anything, provided it was safe.
Yeah.
I would try anything because I'm desperate.
Yeah.
I know I haven't got pH1, and I learned today how bad pH1 sufferers are struggling. Yeah. But for myself, because of my age and because of those concerns, I really would try anything.
Yeah, and Jana, Valerie from Washington, who has pH3, also wrote, I want treatments available for patients with pH3 to control the oxalate levels. So that seems to be a theme. We also have Crystal from North Carolina who has pH1. I can't even imagine what it is like to suffer the way my sister did when she died of pH at 11. Based on what I could imagine alone, it scared me, and I knew I never wanted to go through it. I was diagnosed at 21 when my kidneys failed. I did, in hindsight, pass kidney stones. I just endured the pain. I did dialysis and had a liver and kidney transplant. The kidney had some complications. I received a second kidney from my husband, who I met in 2007 and 2008. I want to convey the importance of finding treatments for rare diseases and the hope it provides so patients do not have to go through dialysis and transplant. Mm-hmm. And then Billy, also from South Carolina, has pH1. Being able to avoid dialysis and the need for transplant and finding the miracle of having a donor would be incredible. We desperately need drug treatments or even drug mitigation of pH1 symptoms. So grateful to all the researchers. I have 6 brothers and sisters. I'm worried they all have pH1 and don't realize it yet. And lastly, we have Irene from New Jersey, who has a parent of a daughter with pH1, writes, whoops, 1 second. While I'm extremely grateful and lucky to have my beautiful child alive, I think transplantation is an archaic treatment. We are in 2020. The advances we have made in all aspects bring hope that we can find a medicine so we do not have to replace organs.
Sure.
So interesting, the various comments and perspectives. Thank you, everyone.
Yes. And I know we only have our Zoom here for another minute, so I know Dan and John, I'm going to give you the final words from the Zoom panel. Dan, why don't you share what is it you're looking for from future treatment?
Just anything we can do to reduce the anxiety that we're feeling about down the road. We're doing well right now, but hearing all the stories from today, anything we can do to help reduce our fears for the future, and infrequency in intake of medicines. If we can reduce that, that would be extremely helpful.
Sure. And is there a particular thing you said your worries for the future? What do you have in mind when you say that?
Well, worried about increased symptoms and all the difficulties that we've learned about today, and to reduce the chance of transplants. That's what we're trying to do as much as we can, is prolong that eventuality as of right now.
Absolutely. Thank you, Dan. And John?
For the future of treatments, as Jana mentioned before, controlling of the oxalate and preserving the health of the kidneys. I know Beth mentioned earlier how that right now there really is no great treatment. Many of the things that you have to do when you're dealing with stones, whether it's a percutaneous nephrolithotomy or a cystoscopy or lithotripsy or getting stents put in, they're all painful and they're all invasive and they all take a toll. So, I think whatever treatment that's out there that can prevent, damage to the kidneys would be really great for patients, but also for the stress that the caregivers have to endure. I mean, for me personally, I'm so grateful for my transplants that I received, but as others mentioned, it's kind of like trading one set of issues for another with the medications I have to take and just worrying about, will I have to get another transplant? And, before I got my transplants, dialysis was extremely grueling, and going 6 days a week, it was very rigorous, and it takes a tremendous toll on your body. Hearing one of the comments before about the person in Nepal that can only go to dialysis twice a week, and they only have the ability to get a kidney transplant, it breaks my heart because, in America not too long ago, people with PH1 were getting kidney transplants, were not properly diagnosed, and their kidneys were failing and they were passing away. So, to prevent people to have to go through that, I think would be invaluable.
Thank you so much, John. And thank you to our whole Zoom panel for being here and sharing your thoughts and perspectives throughout. We do have a couple of phone callers that came in to speak to this topic. First, we have Allison from New Jersey, who's a caregiver of someone with PH3. So, Allison, welcome. Are you with us?
Hi, hello.
Yes, welcome. Would love to hear if you have any...
Hi, thank you for putting this together today.
Of course.
I am Allison. We have a 3-year-old son that was diagnosed with PH3 prenatally through a standard genetic testing panel given by my OBGYN when I was pregnant. Currently, we have experienced no stones or symptoms, but we have been extremely proactive in monitoring this extremely rare disease. We have had frequent ultrasounds almost monthly when he was under 2 years old to try to find anything that even resembled a stone before his kidneys got covered or something like some of the other stories that we have heard. At 4 months old, he began taking the potassium citrate solution several times a day when ultrasound scans showed possible stones. While we are trying to determine if the benefits of the citrate actually outweigh the negatives, or are we actually asymptomatic to PH3 to date because we have never experienced any clear-cut PH3 symptoms. We're not sure if he tolerates the citrate well, but that is still undeterminable as he is extremely young and it's hard for him to communicate his wants and needs. This is a constant worry which leads to high anxiety as a parent and to our family for our current and the future. Anytime we tell regular doctors, if we bring my son to a regular doctor for any appointment, they right away focus on this extremely rare disease and feel that their diagnosis needs to be geared toward something that they have no idea about PH3. Because there are so many unknowns with PH3, we aren't looked at as a normal child. But again, we're not really sure what the future holds. Right now, maybe he's just asymptomatic, or as other callers have said, it was pretty controlled until it wasn't controlled. So any future treatment, it would really lower my anxiety and our family's anxiety for our future and future generations to come.
Yeah, absolutely, Allison. Thank you so much for sharing that. Really, I think a unique story we haven't heard about the prenatal diagnosis and being able to monitor and hopefully get ahead, it sounds like, of the symptoms. So thank you so much. Our last caller of the day before we finish out with any remaining comments that might have come in is Karen from Calgary, Alberta, who has a caregiver of a son with PH3. Karen, would love to hear your comments on this question. What would you be looking for from a future treatment?
My son actually hasn't suffered from any stones since he was about 15 years old. But I did want to make a comment that from about the time he was 9, and he wasn't diagnosed until he was about 18, he had suffered from a number of different stone events, which needed surgeries. But what I wanted to say was that we were able to control his urinary oxalate output by controlling the amount of complex carbohydrates he had. I was online fishing around looking for information regarding kids with kidney stones, and I found a thread that had said a dad found that his daughter's urinary oxalate output was controlled by diet, and so we put him onto a diet which excluded complex carbohydrates, and we were able to bring his urinary oxalate levels back down into the normal range. So from the time he was about 12 until the time he was 19 and went away to college, we actually did that, and he had no more stone events as he got older. And now he is 26 years old. He does not follow the diet, but he does try and control the amount of complex carbohydrates that he is consuming, and he hasn't had any stone events since that time. So I just wanted to add that maybe that was an avenue that could be researched at some point in time.
Sure. Thank you so much, Karen. Really appreciate that. I'm going to check in with Kim one last time. Anything?
Yeah, I just want to say thank you for all the comments. They've been incredibly helpful. We recognize, based on the many, I would say 20 to 30 comments that I've received, the overall theme is that we need more treatments, and we need treatment options so that we could preserve kidney function and avoid transplant if possible. And that's been the overall theme that we're hearing, not only from PH1, PH2, and PH3 patients, but also patients that even had transplants that are not or requiring a second graft or a third graft.
Absolutely.
Yeah.
Yeah, thank you, Kim. So thank you, everyone. This is the conclusion of the part of our program where we're asking you to call in, write in, do those polling questions. You all have been wonderful today. We've gotten so much information and learned so much about PH, what it is to live with it, and the unmet needs that you all have given what treatment options are available. I have to say, as your moderator, I'm just, in a debt of gratitude to all of you. You really, pulled back the curtain today. You did not sugarcoat what it meant and what it actually looks and feels like to live with this condition. And I think because of that, we have a much clearer picture of what it is we actually need to help you all with. And so, as someone that's been doing this, working to make sure that patients have a voice in drug development and in regulatory decision making for over 10 years, I know the input that you gave today is going to have an impact. So I just really want to thank you for being so willing to share. It is really an act of bravery. So with that, we're going to move into some summary remarks to capture. It's a difficult job and certainly an impossible job to try to capture everything that we heard today. But We have Larry Bauer, my friend and colleague, who's going to be providing a bit of a summary. A little bit about Larry. He spent 17 years at NIH as a clinical research nurse. After that, moving to the Food and Drug Administration, where he co-founded the Rare Diseases Program and worked there for 10 years to help with drug development in rare diseases and engage with patients. So he's been a core part of this planning team to put this PFDD on, and so we're probably in no better hands for this summary. So Larry, take it away.
Okay, thank you very much, James and Kim. As James said, it's been an extremely full day, and I am going to make a feeble attempt to try to summarize as best I can. I will hit certain notes and certain points that were made, but there's no way that I can speak to everything. It was a full day of a meeting. But please know that after the meeting, we will produce a Voice of the Patient report. And in that report, it will be a much fuller description of everything that happened today. So to begin the day, we opened the meeting with Dr. Eliza Thompson from the FDA, who graciously gave some opening remarks. She said that the FDA was here today in the audience to listen and learn from patients and caregivers of people with PH. And she said that people with the disease should be at the center of the drug development process. This is a critical thing and speaks very strongly to why we had this meeting today. And she said it takes a village, which was very evident today as you called in, and we saw people calling in from all over the world. After Dr. Thompson, we heard from Dr. Milner from the Mayo Clinic, who gave us a disease overview. She talked about the 3 types of PH, PH 1, 2, and 3, and possibly other forms that haven't been detected yet. This is a very rare condition with only 1 to 3 people per million. So on the rare disease spectrum, this is definitely at the low end of rare diseases as far as how many people have it in the country. She talked about that it's caused from a genetic mutation that causes the liver to make too much oxalate, and that oxalate in healthy people is usually excreted by the kidneys. But when it's not excreted, it can cause cell and tissue injury, obstruction, infection, and injury to multiple organs within the body. It can cause kidney stones, kidney disease, the need for transplant, and systemic oxalosis. She mentioned that one of the first symptoms that people experience and that we heard over and over again today was with people having kidney stones, especially at very early ages, like in infancy, which is unheard of. She said the treatments currently focus on high fluid intake and meds to reduce the oxalate. Vitamin B6 helps some people. They try to manage the stone production and manage kidney function. And also a goal is to reduce dietary oxalate. But unfortunately, some people will progress and may need liver transplant as well as kidney transplant and dialysis, which comes with many side effects. After Dr. Milner, we opened with panel 1, which focused on what are the symptoms of PH and what are the impacts of those symptoms. So we heard from Amy, who has a son with PH1 who was diagnosed at age 5. He started at birth with failure to thrive, hypertension, heart block, intracranial pressure, broken bones, and had multiple surgeries. Yet he was not formally diagnosed until age 5. So getting a diagnosis can be a challenge in this disease because it's so rare. He had a kidney stone that was so large it had to be removed through his navel. And then he had a stent placement, but the stent adhered to the kidney, and that had to be removed with laser surgery. So even, the kidney stone removal has many issues. He had oxalate deposits in his heart, which disrupted his conduction pathways. His disease has been progressive, and he's had to miss school. And there's been a loss of social integration that we hear from many of the families that have children, and it's been very impactful on their lives. And another sad thing is that she says he just never feels well. Next, we heard from Kyle, who's currently age 24. He has PH type 3. He was diagnosed at 6 months of age when he first had fever and urinary tract infection and a lot of pain. He said PH defined his life and his childhood, that, you look the same on the outside, but that you're always dealing with symptoms and how you feel on the inside. it sounds like he had a good period, but then symptoms reemerged during his college years and he had to have multiple surgeries. He's become very aware of when he develops new stones, and he says the surgeries have been constant. We heard from Jamie, who has 2 boys with PH2. Just as an aside, it was very impressive that we heard how many families have multiple people in the family that are affected. And this complicates everything. Having one sick child or one sick family member is difficult, but having many just adds layers. Jamie's son, he had high fevers due to his kidneys being filled with stones. He's had over 24 surgeries in his childhood. She said his body is covered with scars, and it just made such an impression on me that she says he looks like the survivor of a shark attack, and that other kids have mentioned that. Her second son was diagnosed after genetic testing. He started out to have more of a mild condition, but as the children are getting older, it sounds like they're reversing the pathway. She says life with PH is constant pain, worry, and fear about the future, that it will bring something far bigger, that another stone, 2 or 3 stones, and that once you have damage, that it may be irreversible. Next, we heard from Natalie, who's 31 years old currently with PH1. She was diagnosed at age 5. She also had this period where she did fairly well for a while, but then it resurfaced at age 29, where she had severe illness and hospitalization with extreme pain. We've heard that over and over again today. This is not typical pain. This is extreme pain that people experience. She had a surgery, but even that surgery damaged her kidneys. She said, she'd always known she had PH, but she saw firsthand how much it can change her life. It's a sinking feeling. Your whole life will be different from that moment forward, that it's something I'll always remember. And then the last person we heard of on the panel from the morning was Jessica, who has a 4-year-old daughter with PH2. She was hospitalized at age 4 months with uncontrollable vomiting and diarrhea, recurrent UTIs, which is very unusual in an infant, and was found to have stones in both kidneys. She's had multiple surgeries. She had a G-tube placed, which we've heard again and again that children are unable to keep up with the large volumes of water they need. So they have G-tubes placed so that they can, be administered water through that method. She said there's many unknowns about the future and what life will be like when she starts school. She spoke about the frustration that when you have a sick infant and they can't communicate, you don't know what's wrong or what hurts. And she said now that Willa is able to communicate her pain verbally, she can tell us where it hurts or that it hurts and where. In the afternoon, we moved to talking about treatments and what people are looking for in the future. The thing we heard again and again is water, water, water. People are forcing fluids every day of their life. It's difficult, especially for kids, to drink large volumes of water. Their stomachs aren't made for it. When people do sporting events, they have to take in even more water because they're losing it. We heard that some people respond to vitamin B6 treatment, which can be an effective treatment, but that's only a subpopulation of people with PH. There's a lot of variety in presentation of PH and in responses to treatment. And we also heard as an overarching comment that many of the treatments are invasive and burdensome. We heard from Christy, who has 2 children with PH1. Her daughter had stones removed through a ureteroscopy with a temporary stent placed. Her son was diagnosed then at 28 days of age. And when he was diagnosed, he already had kidneys that were loaded with stones. And he went into end-stage renal failure at age 5 months, which is just incredible. And he needed a kidney and liver transplant. One of the things that I thought was so shocking was that they placed a catheter into his abdomen, not for dialysis, but to inject so much fluid to stretch his abdomen so that he would be able to hold adult organs when they were transplanted, because his little body was so small that he didn't have the capacity to hold those organs. He's had many, challenges since his transplant. Their daughter also has this disease. She ended up going on dialysis, but she joined a research study and was able to cut down her dialysis to 3 days a week instead of 6. And another startling thing was that she was offered recently a kidney and liver transplant, but turned them down because they're going to stick with the medication and the trial she's on to see how she can do. And maybe down the road, she'll only need a kidney. We heard from Neil, who has PH2 and has had it for 56 years. He had to go on peritoneal dialysis. And at the age of 31, he got a call that a kidney was available. He said it's not a cure for PH and/or oxalosis, but it's the next thing that's available right now. Since then, Neil's had to have 2 kidney transplants. And by the age 47, he was again in end-stage renal failure. He's had to be on dialysis 5 days a week. And despite this, he said the oxalosis continues to cause me many problems. So finding a better treatment or medication that would truly change everything and give PH patients a genuine hope of leading a normal life is something that has driven him to continue with research and all the tests that he goes through. We heard from Sarah, who has 2 children, once again, with PH2, a daughter diagnosed at 11 months after 4 months of vomiting and seizures and extreme pain. She had stones with ureter blockages. At age 2, she had 19 stones removed. She had to be treated with an antibiotic, but she said it had to be given slowly because, once again, this was a treatment for the urinary tract infection, but it was so toxic to this young body. So they had to give it slowly over hours. Then her son was diagnosed at 1 month of age. She said her daughters needed a G-tube, but the son can keep up with oral water intake. And once again, we heard a big impact on their school and social lives. It affects their self-esteem. They've tried several natural remedies to try to break down oxalate. And she mentioned the story too about her daughter once being so dehydrated from vomiting and dehydration that they had to stick her 17 times to try to start an IV, which is a challenge when someone's dehydrated. We heard from Michelle, who has 2 children with PH3, which is the rarest form of PH. Her daughter started at 7 months with stones. She talked about how challenging it is to get an infant to drink large amounts of water. One of the impressive things about their story was that their son had an episode of traumatic pain that was so severe that this little boy passed out on the floor at home. They had to call 911 and take him to the hospital to, revive him and relieve him of the pain. Both of her children take hydrochlorothiazide, which we usually think of as a blood pressure medicine, but she says it helps keep the urine clean. And the daughter takes potassium citrate, which has very large pills that can choke children. They hope for a medication that's at least invasive as possible and something that could be given at home. And she said if they could take 1 pill a day, that would be ideal. Next, we heard from George, who's 16 years old with PH1. He was diagnosed at age 8. He takes potassium citrate, which helps the pH, but it gives him a stomach upset. He said his wish for new therapies were that something to help treat the excess oxalate production so that I could maintain kidney function that I have, and also a therapy that would help improve my kidney function. His mother, Jennifer, talked about George's history and said that he had stones that obstructed both kidneys. One of those stones, as he tried to pass it, obstructed the tip of his penis, and he had to have an extremely painful surgery to remove it. I thought it was interesting. She said that playing Chopin nocturnes helped George to relax, which was kind of amazing. It's kind of a music therapy intervention. Stents really helped him. While he was in the hospital, he was almost mistreated with Lasix. Lasix would have caused his potassium to pivot, or to plummet, and he was already, had a low potassium level. There could have been very serious repercussions because the physicians didn't understand this condition. George is also very motivated to participate in trials. So we've heard that all 3 types of PH are serious. They have great impacts on people's lives. There continues to be tremendous unmet need. The 3 types have defining characteristics, but also a lot of commonality and share some of the same symptoms. They all develop kidney stones. There's multiple surgeries, need to constantly worry about hydration, and always worrying about getting enough water intake. People expressed wanting to reduce oxalate levels, reduce their fears of the future and what might happen. reduce the amount of medication they have to take, reduce the needs for transplants, and they hope for the future that we will be able to develop less invasive treatments. So on that note, I'd like to turn the meeting back over to Kim, who will finish the day for us. So thank you very much.
Thank you, Larry, for that amazing overview. And thank you both to our speakers, Dr. Dawn Milliner and Dr. Eliza Thompson. We couldn't have done this without you. Wow, what an incredible day. All the stories and comments have truly touched my heart. I am inspired more than ever to continue our work to help find treatments and an eventual cure for primary hyperoxaluria. If you are viewing this live stream for the first time or we didn't get to your comment today, don't worry. You have until November 4th to submit your comments through the online comment form so that we can include all your responses into the Voice of the Patient report. This report is 100% driven by you, and your comments will help shape the future of PH forever. Today was such an incredible day. I'm feeling so grateful for all the people who help make this meeting a reality. Thank you to the FDA staff members who tuned in today. We know how hard you're working right now, even in the midst of a worldwide pandemic. We appreciate you taking the time out of your day to join us. A special thank you to Shannon Cole from the FDA, who was our guiding light through this entire meeting process. To our meeting sponsors, thank you for believing in the OHF and allowing us to make this meeting possible. A huge shout out to Dudley Digital, who somehow made all this magic happen today for a seamless production. To Mayo Clinic Hyperoxaluria staff, thank you for all your help with today's broadcast. My gratitude to James Valentine and Larry Bauer for being such great partners over the past year. Thank you to Dr. Todd Lowther and Dr. John Liskey for all your guidance. A special shout out to Julie Bertarelli, who worked around the clock. You truly went above and beyond. We couldn't have done it without all of you. And finally, a heartfelt thank you to our panelists for all the time you committed in prepping for this meeting and sharing your stories today. And to all of you who called in or submitted comments online. Your passion and bravery is like a beacon of light around the world. The impact of this meeting will be felt for years to come. Thank you all for making today a major milestone in the continued quest to find treatments for primary hyperoxaluria. Bye for now and stay well.